We're going to get started, everyone. Perfect. All right, welcome. We're excited that we get to kick off RMIE with the Fellows course. I am Anna Deloy.
And I'm Mohammed Bilal. So we're really privileged to welcome all of you 60 plus advanced fellows and general GI fellows across the country for our course.
And we were joking about this a little bit. Not only are we the course directors for this course, but we share program directorship for the advanced course. And during our interviews, people were like, you guys only take one fellow. Why do you need two of you? And really, it's just so that we can hang out more with each other. We really enjoy doing this and putting it together. So hopefully that'll show for all of you.
Well, and like Dr. Deloy said, but we also have this course has a rich history. This is the 19th year that the Rocky Mountain Interventional Endoscopy course is happening. Probably one of the longest running live endoscopy courses in the United States. And this is me actually attending Rocky Mountain Interventional Endoscopy course in 2018. And I would say that this course really changed the trajectory of my career. I never thought I'd be one day director of this course. So I hope that many, many of you will be inspired by this course, just like this course inspired me many years ago.
So we have a great day for you. We're going to start the day with lectures. Then we'll take a break. We'll have lunch and we'll go over to our endoscopy suite and do hands-on. We'd like you guys to save your questions. So we'll do a bunch of lectures, then we'll have a Q&A session. It's going to be very informal. We want to encourage you to ask everything. We're going to get all the faculty who's here to get involved, answer things. And then we will head over, like I said, to do the hands-on. We just want to highlight, we'll introduce this when the lecture comes up, but Brian Brower was one of my mentors, a dear friend and colleague to all of us. He was my program director. He passed away way too soon, so we just want to highlight how much we miss him and how this course is really still in honor of him.
And this year, the Brian Brower lecture will be given by none other than Dr. Ellen Barkin, who's joined us from McGill University on endoscopic management of complications. And then the main course schedule. So obviously today is dedicated to the fellows, but tomorrow we have our full day of live endoscopy courses where we have incredible national and international faculty who will be doing live cases. There will be, and then followed by on Saturday, we're going to have didactics with live endoscopy talks as well as debates on hot topics in endoscopy. And of course, the course is only good as the faculty. So thank you to our incredible faculty. We have an incredible list of faculty from all over the country. We have about people from 32 states registered for this course, and faculty and fellows coming from over 10 countries participating. And you'll also see some faculty who will be doing live streaming from cases from India and Ecuador. So we're really looking forward to that. At the end, go ahead, Dr. Deloy.
We want to thank all of our supporters. So thank you to Boston, Olympus, Cook, Irby, Ovesco. Thank you all for making this course possible.
And then lastly, but not, you've all gotten emails from one of our course coordinators, Christy Click. So big shout out to her. If you see her, say her thank you. She really put a lot of effort to it. And also we're so grateful to our endoscopy program leadership with Dr. Steven Mundavis, need no introduction, former ASG president, who's really a backbone of our unit, and Dr. Sachin Wani and Dr. Raja, who've helped us put us a great course, and all of our local faculty who've helped us with this incredible course that you'll see. So with this, welcome. This course is for you guys. Like Dr. Deloy said, we both would welcome anything, any questions you have. All the faculty are here for you, have blocked all their schedules. So please ask us anything during the next 3 days. Don't ask me anything about Denver. That's up to Dr. Deloy because I'm still new here. But anything else is all fair game. So
we want to introduce our first speaker, Dr. Ryan Law, who's coming to us from Mayo. He is going to go over some of the cornerstones of cannulation. So we'll get him up here and get the course started. Thanks, Ryan.
Thanks to the entire crew here at Colorado for having me. I appreciate the invite. So we'll spend the next 20 minutes or so talking about cannulation, obviously an incredibly important topic, incredibly important for all of you as fellows early on in your advanced fellowship. First and foremost, I feel like I need to have a disclaimer that this is kind of my outlook on how to do these things. I don't want you to go back to your home institution and tell your mentors there that I told you to do something different from what they're telling you. So this is kind of how I teach things, how I see this. We'll spend some time discussing anatomical, technical considerations for selective duct cannulation. We'll talk about some alternative techniques when primary conventional cannulation fails. And then we'll finish a little bit with some special situations at the end. So as we all know, consistent, efficient, safe cannulation is one of, if not the most important ERCP skill. What I would tell you is that this is something that you can always get better at. There's nobody who has kind of reached the point where you can't get better. There's little nuances and tricks that you'll pick up over your career to improve your skills with cannulation. It really is never ending. I've seen people recently kind of show videos or techniques that I think are worthwhile and I've never thought of. So it's important to always be aware and observant of ways you can improve your own set of skills. I would say that cannulation begins with visual inspection. Obtaining a short position in general within the second portion of the duodenum and really inspecting the major papilla. First and foremost, discerning if you think there's one orifice or if there's two. If there's any periampullary diverticulum or if the ampulla sits completely within the diverticulum, that's certainly going to change how you move forward. And then any potential pathology. Some of this you're going to know ahead of time and may be the indication for the case, but being observant of if there's adenomatous tissue, suspicion for an impacted stone, any sort of biliary fistula, all can be sorted out in the first couple minutes of following scope passage. Some anatomical considerations. Realize that generally we see a single papillary opening which leads to two ducts. There can be anything from a very short common channel where the septum, which runs diagonally, can be immediately after the single orifice, or a very long common channel where that septum sits back a bit and may make your ability to selectively cannulate a bit more challenging. If you think of the papilla sectioned into quadrants with the vertical fold in the duodenum at 12 o'clock, the bile duct is most commonly in the left upper outer quadrant, with the pancreatic duct kind of, I wouldn't say necessarily the right lower quadrant, but maybe 2 to 4 on a clock face. Keeping in mind that any changes in anatomy, whether it be the presence of a tumor, duodenal diverticula, may alter the position from any kind of standard expectation. Most commonly, the bile duct runs upward. As you can see here in the schematic, this bile duct runs upward, whereas the pancreatic duct tends to run more straight inward. The other thing to keep in mind is not only does the bile duct run upward, it runs upward with your scope, with your small dial turned to the right at least slightly in most situations, whereas access to the pancreatic duct is either going to be with a neutral small dial or at least less right than the bile duct. And this is just schematic showing what I told you for visual learners here about where we typically see the orifice. In terms of cannulation, that's important for scope position. We generally try to maintain a scope position somewhat underneath the papilla. Typically, if you're working at or above, you're either more likely to get in the pancreatic duct or not to get into anything at all. So ideally, obtaining a short position where you're slightly underneath the major papilla, looking a little bit up at it, is going to be your most likely scenario for successful primary cannulation. I include this slide in talks like this because when I was part of video GIE, this came through, and when I first saw it, I didn't really know what to do with it. But the more I looked at it and the more I read it, this is actually conceptually brilliant in my mind. So what the authors from Japan are proposing is that when you look at the major papilla, you think of it in terms of a stack of compact discs. If you don't know what a compact disc is, please raise your hand. Okay, good. That makes me feel somewhat better. And just thinking about how the bile duct, particularly the intraduodenal bile duct, orients itself. So you can see the image on the far left, very straight, relatively fixed intraduodenal bile duct. Thus, they demonstrate these three stacked CDs in a straight line in comparison to the one on the right, where the intraduodenal bile duct tends to take a screen left position. So that might be something to keep in mind early on in your career, just as a conceptual reminder of how to think about this. Now, some basic cannulation tips. Again, we talked about examining the papilla. Realize that while we generally strive to achieve short position, that may not be optimal in all patients. The optimal position for cannulation, getting you close to the papilla for successful cannulation, may be in a long position. Typically, long position is by advancing your scope and dropping your left hand, and it'll kind of keep you in the second portion, but often gives you a much better view. So don't lose sight of that. There's a lot of ways to cannulate. My preference is to use a sphincteratome with a completely hydrophilic guide wire. A lot of people like straight guide wires or partially hydrophilic guide wires. I like a completely hydrophilic wire with an angled tip. And your goal should be to aim over the top of that septum into that left upper quadrant. I'm not a big proponent of using a guide wire tip. I know a lot of people do. The one thing I would tell you as a fellow that you have to consider, don't get so worried about what the guide wire tip is. If you're worried about the orientation of the tip in terms of cannulation, then you're spending too much time on that concept. It really should be a very, very small amount of guide wire tip if you're going to use that approach. Some people do, some people don't. I wouldn't necessarily say that it's a must, but if you find it helpful, go for it. And then in terms of guide wire passage, this really should be done with small forward movements with an emphasis on torquing, in particular if you're using an angled tip wire. I only use full strength contrast. I don't believe that contrast should be completely eliminated from cannulation. I think there's certain scenarios where you're trying to get in, you reasonably think that you're in the bile duct. There's no problem with giving a puff of contrast to see if you're able to find the bile duct. Studies showing increased rates of pancreatitis related to contrast injection are generally in the days where we would seat the sphincteratome in the major papilla and then do a large volume contrast injection, fill out the whole pancreaticobiliary tree. That I would advise against, but there are scenarios where using a small amount of contrast can help guide you, particularly if you think you're in the right plane or the right position. Be gentle when you're trying to access the major papilla. What I was taught by Todd Barron when I was a fellow, he as many of you who know Todd, he makes a lot of weird analogies, but one that stuck with me was docking a space station at the space station, where it has to be absolutely perfect. It can't be too hard, it can't be too soft. It has to just kind of be perfectly lined up in the perfect orientation. So keep that in mind. Also, that will allow you from a fellow perspective, being gentle when you're trying to cannulate will allow you to keep the scope in your hand a heck of a lot longer than if you are beating it up a little bit and turning it into hamburger. So just be really gentle. It's incredibly important in that perspective. When you have a large intraduodenal bile duct or a lot of folds over the bile duct, because the more pressure you put on that, the more that bile duct crimps and the harder it is going to be to cannulate. So be very gentle in that situation. And then I utilize a stepwise approach for cannulation. If I line up my duodenoscope and sphincteratome here, and I'm going to cannulate and it doesn't go, I make very kind of incremental movements along the clock face in different directions to try and find. I have a systematic approach, and I would encourage you to develop the same. So failure of primary cannulation. First question is why do you fail? Is there a diverticulum? Is there a teardrop papilla? Is there a huge intraduodenal segment with a lot of folds, impacted stone? So it's important to think about why you failed, and that's generally going to guide your next steps. In terms of how long to persist before second steps, I think it goes back a little bit to what I was just talking about. I think it's okay to persist so long as you're not getting a lot of papillary edema. And also so long as you reasonably feel like there's a chance that you're going to succeed with your primary attempts. If you've kind of made the decision that we need to move on to secondary steps, you have some options. You can change devices, or you can change to a different approach, like a guide wire placement in the pancreatic duct, which we'll talk about, or you can institute techniques for pre-cut. This is something I just wanted to show for cases of a duodenal diverticulum. So this is a case we had completely intradiverticular papilla, couldn't cannulate, tried. This is an approach I would tell you to try. This is saline injection into the peridiverticular space. And I will promise all of you that this will work. This will not work all the time, but it will work sometimes. And considering that if you don't get in, you may be doing more aggressive things. This is a good approach to consider. What we do is you have to look and find out where the orifice sits in relation to the diverticulum, and it's very much a similar approach to what we utilize with duodenal or with complex colon polyps. When you're trying to lift to in your favor, okay, lifting the polyp towards you for resection, finding the optimal angle for putting that saline injection into the peridiverticular space will give you just enough time in many cases to get a good orientation to the major papilla and allow cannulation. So I've had a lot of people not believe me that works, but I promise you if you try it, it'll work sometimes. All right, so in terms of equipment change, this really comes down to personal preference. There's a lot of ways to do this. I can tell you that anybody who tells you this is the best way for pretty much anything in therapeutic endoscopy is a bit out to lunch. There's so many ways to do everything we do, and many ways, or many situations, nobody's really wrong. What I would say is be comfortable with your routine. If you get in a habit of switching to a smaller caliber guide wire, then have that be part of your routine. If you like to switch to a cannula as opposed to a sphincterotome, that's also fine. It just comes down to really the patient and the situation, but also kind of how you want to go forward and what you develop as part of your process. Again, you can switch from an angled wire to a straight wire, a stiffer wire, a less stiff wire. In many cases, you may need to change both. But it really just comes down to what works for you and what you become comfortable with over time. Now, if you get inadvertent access to the ventral pancreatic duct, I would recommend using it. My typical scenario is that if I get a second access into the pancreatic duct, I leave the wire and go to double guide wire technique. There's a lot of people who don't like using two guide wires, so they would put a pancreatic duct stent in at that point. I think either is certainly a reasonable option, but there's a lot of benefits for utilizing that pancreatic duct. It stabilizes your position for cannulation in many ways. It gives you an idea of where that pancreatic duct trajectory is, and straightens the duct and the common channel. It also helps to maybe separate the two, the pancreatic and biliary orifice. It partially, probably not completely, partially obstructs the pancreatic duct. So maybe guide wire advancement into the pancreatic duct with your second wire is less likely. I think most of us would tell you that unfortunately, it seems like even with the second guide wire, the first guide wire doesn't really obstruct it. You seem to find your way in there with the second one often as well. And then also it can direct your pre-cut if you get to that point. So at least you can protect your pancreatic duct with the wire or a stent, and then cut off of that to potentially prevent any increased risk for post-ERCP pancreatitis. This is a strong recommendation from ESGE. These are guidelines from 2016. To my knowledge, they haven't been updated from this society, but they recommend using a pancreatic guide wire where you have repeated unintentional access to the duct. moderate evidence, but a strong recommendation, and I would agree. It's certainly a good technique as a fellow to at least be comfortable with and be able to do in the situations where you'll need it. This is just a schematic of the double guide wire kind of in a cross section. So again, the goal is you use the guide wire to straighten everything out and then work above it. I think this middle picture tells a lot of the story. The way I look at it in most cases, if your guide wire is headed kind of to a 2 o'clock position, 3 o'clock position, your cannula or sphincterotome has to cross it in some way. It's often not going to be in the same plane, but sometimes it generally has to cross it. So once I have a guide wire in, that's kind of my first approach is crossing that guide wire with the sphincterotome with the hope that I'm going to get into the bile duct thereafter. A similar approach with a stent, you can see here in the endoscopic image on the right, same idea. This sphincterotome goes directly across the plastic pancreatic duct stent to engage the bile duct. Now, when we think about pre-cut access techniques, you have some choices. We talked about cutting over a guide wire or cutting over a stent. You can also cut freehand. If you're unable to get any ductal access, then that may be the only option you have. And if you're going to cut, are you going to cut a fistulotomy or a sphincterotomy? There is some data to show that a fistulotomy has a decreased rate of post-ERCP pancreatitis. And what we mean by fistulotomy, I'll show you a video in the next slide here, but literally cutting above the papilla, a freehand kind of stepwise cut. I think of it or describe it to our fellows as kind of peeling an onion. There's no reason to make this giant, freehand cut. You kind of take it one layer at a time. Hopefully you're able to get to the point where you see free flowing bile and you've reached into, the bile duct orifice, but it's very important to do it as a stepwise approach. You can cut towards the major papilla, you can cut towards the transverse duodenal fold. That's really a personal preference. In terms of pre-cut sphincterotomy, generally this is described as using a needle knife to grab the biliary orifice or the opening to the major papilla and cutting in the trajectory of the perceived bile duct directly from the orifice. Goal is to aim your needle knife at the 10 or 11 o'clock position. I do recommend, particularly early on in your experience, that you should take some practice swings before you use cautery. So you can kind of line up in the angle you think you're going to take, see how the knife is going to react with your elevator, using your big wheel, different parts of what you think you're going to need to perform the pre-cut. But take a second to just make sure that when you actually apply energy that you're going to get the cut that you want. As we said, superficial incisions to dissect layer by layer, and then ultimately maybe a little gentle blunt dissection to identify biliary mucosa and gain access. I like to do this with a wire more than anything. My concern, I've had enough cases earlier in my career where you're convinced that you're in the bile duct, you inject contrast and you're adjacent to the bile duct in a false tract, and now you have this blob of contrast in your way that preclude maybe successful efforts thereafter. So I try, or my goal is to always get definitive wire guided access into the biliary tree before I'll inject any bile. Also, don't hold your hat that you're going to see a big rush of bile. Everybody who presents these techniques, there's like this aha part of the video where bile comes pouring out. I would tell you that that's not always the case, regardless of the pathology. So just keep that in mind. And then after your pre-cut, you may need to extend your sphincterotomy. It depends on what approach you choose. It depends on how large your pre-cut is, and then also what you're trying to accomplish in that procedure. So here's a fistulotomy. I tend to do fistulotomy over sphincterotomy. In this case, we cut down towards the major papilla. Looks like you can start to see maybe a little trickle of bile, but the bile duct opening, and then subsequently we're able to gain access to the biliary tree. This was a good case, in my opinion, for fistulotomy, given that you had such a large target and that intraduodenal segment. Finally, just to touch on EUS guided rendezvous, I think this is probably part of other talks. This is a good bailout, although I don't know that it has as much of a role as it perhaps did previously. You can access the biliary tree either from the left hepatic duct or from the common bile duct under EUS. And then ultimately what we're hoping to achieve is guide wire passage through the papilla into the small bowel to allow conventional ERCP. So the guide wire is then left, leaving removing the EUS scope and replacing it with an ERCP scope, where conventional cannulation can be achieved either alongside your rendezvous wire or by grasping it and utilizing it over the guide wire. Say about an 80% success rate in published literature, 10 to 20% adverse event rate, the biggest risk being bile leak. Not an easy procedure. I would have to say one of my least favorite, because it's always there's always something about it that's complicated in terms of making sure you don't twist the wire. Can you get the wire from either the left hepatic duct all the way down through a stricture or past a stone? If you use a approach from the duodenum, your trajectory is upward, which isn't favorable. So a difficult procedure, but kind of the ultimate bailout in situations where you're trying to get bile duct access. Here's a very quick rendezvous video. This is for the fellows, this is an exceptionally well edited video. It never goes this smoothly. Anybody in the room will tell you that. Basically, there's this amazing guide wire passage straight south out of the bile duct and into the duodenum. Again, we leave a lot of length of guide wire in the small bowel, then remove the EUS scope, replace it with a duodenoscope. In this case, we did grasp the wire, ultimately gained access, and then left a fully covered metal stent for, I think, treatment of cholangitis in this case. So in conclusion, what I would tell you as fellows, have a keen awareness of all of the available equipment, both in your unit and equipment that you can have access to that may be of benefit. Develop a routine, use what works for you. Again, there's almost no evidence to suggest that many of these things are superior to another technique, particularly as it pertains to equipment. So if you're comfortable with a particular guide wire, catheter, sphincterotome, it's okay to use it. I would encourage you to try new things, but only after you adapt a solid, comfortable routine. It's not great early on in your career to just continually try new things, because it's very hard to develop a kind of a plan or a skill set or anything in that situation. Understand the value of fluoroscopy beyond contrast injection. It'll help you define guide wire passage into the ducts of interest. It'll also help you visualize trajectory and cannulation in many situations, duct selection as well. And then become comfortable with techniques for secondary cannulation. Thank you.
Thank you, Dr. Law, for an excellent presentation. We'll do a Q&A at the end of each session. So next up, it's a privilege to introduce Dr. Jennifer Fan, who's the medical director at Hoag Medical, is truly one of the leading educators in our field, also as a director of bariatric endoscopy and co-program director of the Advanced Endoscopy Fellowship. And she's going to go over cholangioscopy and pancreatoscopy 101. So thank you, Jen. Yeah.
Thank you, Bilal, and thank you for everyone for the invitation to be here. It's a pleasure. So I'm going to talk about cholangioscopy and pancreatoscopy 101, but hopefully going a little bit beyond that, given that many of you hopefully have already touched the cholangioscope. So a brief history on cholangioscopy. In the 1980s, we had the mother and daughter systems that were introduced. And the nature of the design that it required two endoscopists. Now, Bilal and I don't know this because this is kind of the era when we were born, but many of the people in this room were crucial in the advancement of cholangioscopy. So we thank them for their innovation in this field, that we don't need two endoscopists for this. We had the Piers way of doing this, which is a percutaneous endoscopic extraction of retained stone. So it was a thin caliber endoscope that could percutaneously get introduced through a mature T-tube into the biliary tree. Now, there are times when this has been used in the last few years when you're trying to do kind of more creative work with our IR colleagues. But luckily now there's a scope for our radiologists in particular, and there's a scope for us, making this need for collaboration less necessary and less needed. Then we have catheter-based systems. For a long time, we had the Spyglass direct visualization system, but you all live in an era where the cholangioscope itself has really undergone a lot of innovation in the last few years, where now we have size preferences, we have device choices, which allow for more accessory choices. So these are the nitty-gritties of the cholangioscopes that are currently on the market or under evaluation or research. So we have the Spyglass, we have IMAX, Dragonfly, and then VedVision is mostly in Europe. And you can see now that there are variations in the size of the cholangioscope, really in order to change the accessory channel width. So the previous limitations on the accessory channel width only allowed for certain biopsies to go through, certain accessory devices to go through. But now that there's variation in sizes, we're able to get bigger, better utilities into the bile duct and into the pancreatic duct. VedVision in itself is a little different. It's in Europe. And the difference here is that it has its own wire-guided port. So it doesn't require removal of the wire in order to get any accessory through. And with that, we have multiple through the cholangioscope accessories. You have the EHL probes, the laser lithotripsy probes, the biopsy forceps, retrieval snares, and retrieval baskets. But innately, we hope that in the next 5 to 10 years, we have an even more diversified portfolio of accessories to go through the cholangioscope. So how do we use a cholangioscope in general? This is kind of our wheel of applications. So difficult bile duct stone management, targeted tissue acquisition, selective biliary duct access, and ductal clearance. Can't underplay the utility of cholangioscope for this particular indication, which is as we start to do more things in the gallbladder, doing cystic duct drainage, is that selective biliary duct access is key in order to get to where we need to go. And a cholangioscope is very useful for that. Intraductal tumor delineation and staging, tumor ablation, foreign body removal, and pancreatoscopy. We won't go through all of these, but we'll go through some of them. So since this was given the title of cholangioscopy 101, we need to start at the beginning. So we are taking a stiff scope and putting it into an angle that is not natural for how the elevator closes and how the accessories typically come out of the side viewing scope. And so there are multiple different ways that you'll see people getting into the duct, whether it's over a wire, right? Using kind of a pole vaulting technique, being straight in, using over the wire, pushing back a little bit, and then pole vaulting your way in. There's the making your cholangioscope into a sphincter tome. So using using the dials of the cholangioscope itself in order to anchor your way into the bile duct, just like you would a sphincter tome. We just had a great talk on the angles of how to get into the pancreatic duct and into the biliary duct. And now you can make your cholangioscope into that configuration. And last is kind of using the visualization of the cholangioscope itself to help direct you into the bile duct itself. So again, taking something rigid, making it flexible, going into a duct. It takes nuance and how to do it cleanly with getting into the duct that you would like. But these are little tips and tricks of how to get into the bile duct using the cholangioscope. So first, we'll start off with the management of difficult biliary stones, and you'll see kind of variations in practice here. And so these are the typical times when people will bring out a cholangioscope. So when you have a large biliary duct stone of greater than 1.5 centimeters in diameter, if you have an impacted stone in the bile duct or the cystic duct, if the stones are in the intrahepatic location, making it difficult for accessories to get into that location for sweeping, if the stones are very hard in consistency, if there's a distal stricture to the stones, and if there's anatomic variation. Now, if you ask many of the advanced endoscopists here, we'll get different algorithms of when we take out a cholangioscope. Many will take out a basket first, a mechanical lithotripter, in order to crush these stones, in order to pull them out. Many of us will go straight to a cholangioscope and go straight to laser or EHL. Variations on how we practice, again, like Dr. Law said, many ways to do it right, but you figure out what's good for you. And so in a meta-analysis of 31 studies, the success rate of taking out a difficult stone via a cholangioscope was around 88% with a low adverse events rate of 7%. And this was when we were still having issues with bleeding or some issues with infection. So how do we do this? And I used to practice with James Buxbaum, who does a lot of stuff with pancreas and biliary work. And so he likes to make sure that when fellows are doing the drilling, that there's mindness to the madness, that you're not just drilling for drilling's sake without any sort of direction of how the energy is flowing. So if you have certain stones, sometimes you want to kind of drill in the middle of the stone to get to the epicenter, to the core of the stone. And so this was back when I was at USC, where we were lucky enough to have both laser and EHL. And so that you can see that this is a laser case with the green light in the middle, and you want to kind of drill in the middle in order to see the core. There are times when you may need to do a horizontal seesaw movement back and forth, especially if you have a clustering of stones. Drilling in the middle may not be as effective, because then you have dispersal of the electrical wave across multiple stones. So you may want to drill back and forth in order to try to get towards the center of each stone. So this is the horizontal saw movements. Or sometimes you need to, this is a pancreatic duct stone, so sometimes you need to fracture the edge of the donut, right, in order to get some sort of movement. Some pancreatic duct stones can be very hard in order to break, and so sometimes breaking the middle becomes too difficult, so you break the edges in itself in order to chip away at the stone. Or sometimes you can't get the cholangioscope or the pancreascope in the center of the stone, then you need to bounce the shock wave off of the side of the wall in order to get an oblique positioning in order to break the stone. So as long as you know kind of how the movement of your probe is going and your intended use of the probe, that's important. We know that it takes a lot in order to damage the bile duct epithelium, but I'm pretty sure none of your attendings want you to actually try to perforate through the epithelium. When we talk about the utility of cholangioscope, it comes without saying that it's very useful in patients with altered anatomy, where you can't get the typical mechanical lithotripter, or the stones are too big to get a basket or to sweep it out. A cholangioscope is very useful. So this is a patient with a Billroth 2 anatomy, multiple large stones, and this is using a colonoscope with then just a cholangioscope through the colonoscope in order to take out these stones, and later putting in a stent and coming back another day to sweep everything out. There are three types of lithotripters: mechanical, EHL, and laser. There are different cost concerns when thinking of which lithotripter you want to go with. So obviously the mechanical ones are the least expensive, don't require a lot of additional costs besides the need to rescue if the mechanical lithotripter becomes caught. There's EHL and laser. I'm a big laser fan. I think it works very well, but requires additional training and safety, as well as the generator itself. We tend to go through less probes when doing a very long case with the laser lithotripter. And so innately the probe costs may be more, but the total use of how many probes that we use per case may go down, especially for a complex case. Next, we go to indeterminate biliary strictures. So these are biliary strictures of persistent unclear etiology after cross-sectional imaging, or if you have an ERCP where brush cytology and intraductal biopsies are either showing atypical cells or not enough in order to give a definitive diagnosis. And so here you see kind of MR imaging and then ERCP, cholangioscopy, or a cholangiogram imaging of a long biliary stricture. And what we know is that the utility of cholangioscopy is not just the fact that you can target biopsies, but that the visual inspection is also very important. And there is, if done by an expert endoscopist, that the visual inspection alone has a high sensitivity and specificity in order to evaluate if a stricture is indeed malignant or not. And so what are we exactly looking for? So we're looking for neovascularization, these kind of tortuous vessels within the biliary epithelium. You're looking for nodularity or a polypoid mass that may be there, some papillary projections or infiltration and ulceration. Now, if you have 4 of these cholangioscopic features, these are highly suggestive of malignancy and neoplasm, so a sensitivity of around 94%. But what we know is that not all strictures are the same. So in what type of scenario do these criteria not necessarily mean that there is cancer there? And the most difficult cases for visual inspection include those that are for PSC. So it's important to know that when patients come in with PSC, we need to know at what phase of their disease they're at. Right? So there are some patients with inflammatory PSC where they're going to get ulcerations and fibrinous white exudate. If it's chronic, they may get patchy erythema with early scarring. Now, if you looked at an ulceration, an acute ulceration during the inflammatory state of a PSC, you may think that this looks like cancer, but innately it's their acute inflammation that's untreated. There are some patients that come in with fibrostenotic PSC, so lots of scarring rings, like you can see here, almost like looking like a patient with EOE, but in the bile duct. And then you have some patients that have nodular PSC, where there's a focal nodular mass that may be there. It may not be cancer, it may be inflammatory, but it's hard to distinguish whether it's a cancerous nodular mass or inflammatory nodular mass. Now, this is a patient case of mine with a patient with PSC, where coming back into the duct, multiple biopsies were taken throughout the long biliary stricture that was there. Got multiple biopsies in multiple settings, and it's my practice that when I take a biopsy, I take a fluoro shot at the same time, so that if, for example, I'm staging the stricture and there happens to be cancer, I can tell my surgeons, well, I took it with this fluoro shot. It's in the distal aspect of the stricture. So this is the patient's stricture. First biopsies, inflammation without dysplasia, inflammation without dysplasia, and then in this nodular area here, cholangiocarcinoma. So patients with PSC, much more difficult to assess just based on visual inspection what is cancer or not. And this is where biopsies can be helpful, and other innovations within this space can be quite helpful. So when do we take out the cholangioscope for biopsy versus doing ERCPs versus brushing? This was a study in GIE in 2020, randomizing patients to ERCP guided brushing versus a randomized to cholangioscopic guided biopsies. And what it showed is that the sensitivity of patients for an accurate diagnosis of cancer was significantly higher in patients who underwent cholangioscopic directed biopsies as compared to those that underwent brushings. So 21% in the brushing group, 68% in the cholangioscopy group. Now, when we look at that in the same view, looking at that with visual impression alone, we see that there's still a sensitivity benefit and an overall accuracy benefit as well. So just on visual inspection alone, the accuracy can go up from 65% to 87% just by the call of the endoscopist on visual inspection. So again, there's multiple advantages of cholangioscopy. There's biopsies, there's higher sensitivity and histologic diagnosis, and there's also visual inspection, so higher sensitivity and overall accuracy in providing a diagnosis. And so when you start to do a lot more cholangioscopy, that visual impression itself helps you target your biopsies to a location of higher propensity of cancer. So what do we mean by high quality ductal biopsies? And remember that cancer doesn't exist just on the surface of the bile duct epithelium. It's buried deep in there. And so what we cannot have are superficial biopsies that come just where the papillary projection comes out into the intraductal lumen. What you really want to get is a piece and a chunk of that tissue. So I tell my fellows, you don't want a ton of bleeding, but you want to see a little bit of blood coming out with these biopsies. You're getting good quality biopsies, and those are the only ones that count for patient diagnosis. So what are the future advancements in targeted tissue acquisition? And I think this is where in the next 5 years, we're going to see quite a bit of innovation in this space. And this is something that will level the playing field in terms of endoscopic experience in visual inspection. And so artificial intelligence overlay is going to be very crucial in being able to help level the playing field for those that maybe do only 5 cholangioscopes a year as compared to those who do 50, 60, 100 a year. And so this is a paper in Nature in 2025 that developed a convolutional neural network to automatically detect and differentiate malignant biliary strictures versus benign biliary strictures. So for example, what we see here based on these outputs is that if it's in green, it's more likely cancerous. And if it's in blue, it's more likely benign. So you can see here, well, you know, Dr. Fan, this one has the classic tortuous vessels that we see. Of course, it's going to be positive for malignancy here, right? But what about this guy here with some projections in the center, right? The neural network, the CNN is calling it as benign. And that's very helpful, right? We want to be able to target our biopsies not to this area here, but really to these areas where there's high diagnostic positive predictive value for cancer. Now, this was an initial paper that showed yes or no, benign or malignant. But what if artificial intelligence can actually tell us exactly where to biopsy that gives us the highest value for each biopsy? So this is a heat map that is generated based on different visualization keys that may determine where things may be positive for cancer. So for example, if the heat map overlies where tumor vessels are, there is a high sensitivity and specificity for cancer in that area. Where there's papillary projections, again, less sensitivity, but you know, if it's positive, then it's very specific. And if there's nodules or masses there, then high sensitivity and specificity. But innately, this heat map tells you if you were to biopsy in this area of red, you're more likely to get a positive biopsy for your patient. Now, what if during your actual cholangioscopy, there was an overlay of artificial intelligence that tells you percentages of where your biopsies may be positive for malignancy. So this was using a different classification, a CRM classification, but innately very similar to the classification we were talking about earlier, looking at spider vascularity, polypoid lesions, ulcerated infiltrative patterns, and honeycombing patterns. And I'll show you a video next, but innately it says there's an 85% possibility that there is malignancy here, that there are less likely areas of malignancy. Oh, you can't see my mouse. Oh. There's a less likely of malignancy in this area here, but if you were to biopsy in these 3 boxes, you're more likely to get a positive diagnosis. So based on this paper, this is what it looks like. Is you're doing your cholangioscopy and you have a box that tells you, hey, look here, because this is where things are not likely to be benign. And so based on this, and using this artificial intelligence overlay, there was a sensitivity of upwards of 90% and an agreement of 80% in determining malignancy. So I think in the next 5 to 10 years, we're going to see a lot of output with artificial intelligence within this space. In terms of adverse events, these were earlier studies when cholangioscopy was becoming more adopted. We saw evidence of cholangitis, perforation, and pancreatitis. Again, the biggest risk factor for cholangioscopy being cholangitis, and now we commonly give intraoperative antibiotics due to this data. So this is my management algorithm for indeterminate strictures. I tend to go very quickly to a cholangioscope because of the data showing that early onset, early adoption of the cholangioscope with biopsies has higher sensitivity and specificity. However, many people still do brushings, intraductal biopsies, fluid aspiration, and fish, and that is extremely right. And so there is many ways to do things right. It's just dependent on how you practice and your experience with that practice. And so once you have you have your obstructive jaundice, you have cross-sectional imaging confirming a biliary stricture. You do your initial ERCP. If you do your brushings, biopsies, fish, fluid aspiration. If it's positive, it goes to oncology surgical referral for treatment. If it's negative, you want to move towards cholangioscopy. Some of us go very early to cholangioscopy, and if it's positive, then it goes to an oncologic referral. And if it's negative, you can either repeat your ERCP with cholangioscopy. You can do EUS-FNA if a patient on imaging is not a surgical candidate, or go to multidisciplinary conference review. Now, for management considerations, it's important to understand the economic impact modeling as well. And so the reason why I bring this up is many of us will eventually transition to a point where we have to take our budgets of our unit into consideration, and their cost analysis modeling suggests that when you do ERCP with cholangioscopy up front, you have a 31% reduction in the number of procedures and a cost savings of around 5%. Now, where do we go next with this in terms of playing a crucial role in the oncologic pathway? And so what we know is that CT and MRIs as part of the pre-surgical planning for cholangiocarcinoma is so necessary, but it's limited by the fact that it's difficult to delineate where the tumor is versus peritumoral inflammation. So what is the role then of the cholangioscopy in helping a patient that's undergoing this oncologic pathway? And so what we know is that the rate of change of plan following a cholangioscopy is significant. And so this was a study that was published in Nature in 2025, looking at patients who had surgery, and they had cholangioscopy done before the surgery. 63% of patients underwent the surgery that was planned for them. 37% of patients had a change in surgical plan because of what was seen on cholangioscopy. And in those 37% of patients, 36% had less extensive surgery. One had more extensive surgery. Some avoided surgery altogether because they were probably underdiagnosed by CT MRI and became non-surgical candidates based on cholangioscopy. And some had conversion surgery. So instead of doing, say, a more extensive hepatectomy, they were able to undergo a partial hepatectomy. What we know is that visual inspection alone was still very correlative to what the surgical outcome was. So in 93% of patients, the visual inspection just on cholangioscopy, not even including the biopsies on cholangioscopy, correlated to what the surgical outcome was. And what we know is that this is reproducible and consistent. So there was a prior study in 2019 showing an 88% overall correlation between endoscopy and surgical histology. Now we see that number getting even higher as we start to get better and better in visual inspection and in diagnostic tools. So this was part of that Nature paper, and this is a very young patient, a 34-year-old patient with a hilar bismus 1. And the initial cholangioscopy views here show diffuse infiltration of the common bile duct, the hilum, the left main, the right main as well. So everything is pretty much positive here on the cholangioscopy. The patient underwent 7 cycles of chemotherapy. Then you look at the following restaging after 7 cycles of chemotherapy, and what you see is now the left main no longer has involvement of that tumor because it's responded to chemotherapy. This 34-year-old then underwent a right extended hepatectomy and a pylorus preserving pancreaticoduodenectomy. And what you see on histology is this is the remaining tumor after the chemotherapy cycles. You have the right main opening, the left main opening, but on histology, he's now had a curative resection, right? So what we know is that part of the things that we can help with is tumor delineation after patients have undergone chemotherapy to see if they can now become surgical candidates, and really being able to show the surgeon there's no tumor involvement here. It's actually fibrotic and scarring involvement that's post-chemotherapy related, but now this patient can go to surgery. Next, we'll go to pancreatoscopy. So there is diagnostic and therapeutic usage of pancreatoscopy or POPs. So diagnosis for the visualization histologic diagnosis of IPMNs to determine if PD strictures are benign or malignant, for tumor mapping prior to resection, and for therapy, lithotripsy in patients with chronic painful pancreatitis with PD stones. And so for early ductal carcinoma, what we know for POPs is basically all the research is really focused on CT, cytology, and innovations within biomarker detection. So CT and cytology have been the focal points of innovation for early detection of early ductal carcinoma. There is machine learning development algorithms for CT and cytological analysis to limit the need for radiology read turnaround times and for rows. But really a lot of the research has looked at innovations in biomarker tumor detection. So liquid biopsies or cell-free DNA or circulating tumor cells, exomes, etc. So is there a role for pancreatoscopy? There's not a very big expanded role here. We should not be doing pancreatoscopy on all early pancreatic ductal patients. But if the role of pancreatoscopy can be done, if it's in conjunction with an EUS, and if on EUS, things don't look as clear as they should, right? So this was a patient where very dilated PD, and you can see that there looks like there's some mucin here, right? Innately, everything else looks pretty good. There's no solid components that are seen on the EUS, but the mucin is there, but there's nothing else to suggest that there's a head of the pancreas mass. There's no solid component within the duct itself. So the surgeon asked if I could do a pancreatoscopy, and what I find is early cancer in the tail. And mucin now has come more proximally, clogged the duct, caused pancreatitis. So instead of taking this patient for a presumed Whipple because of a dilated PD, this patient gets a distal pancreatectomy. So the reason why we don't do common pancreatoscopy is because there's a risk of pancreatitis, but there are times when it may be necessary. So this, I don't know why this is not playing. So these are two different scenarios where an older person with very clear fish mouth, but the surgeon says, I want to take out as little as possible because this person's already becoming diabetic, right? I don't know why this is not playing on the left, but there are, two different patients, older, pre-diabetic, dilated duct here on the EUS, and here we're using DFI. On an EUS scope in order to evaluate some of the characteristics of any possible mass that may be there. These are two different patients, but what you can see here is if you go in with pancreatoscopy, you can kind of help map out what actually needs to get resected. There are different clinical algorithms. So some of us do this for the surgeons intraoperatively if they're taking out a main duct IPMN in order for them to get staged, right? So they cut out a little bit. You can go in with a pancreatoscope and evaluate if all of the duct is clear. We have started to come and pull that forward a little bit because of our experience with pancreatoscopy to help stage some of these patients a little bit earlier on. But you can see here that there are some complexities when dealing with the main duct IPMN, a ton of mucin in the duct. It's like driving in a snowstorm. It's hard to see. But if you can see different papillary projections or masses, it's very helpful in order to stage for the surgeon. So this is a great video by someone who, in this audience here, Dr. Shah, who does organ sparing endoscopy. So this was a great video GIE where someone had really bad pain related to chronic pancreatitis, ductal hypertension. There's a stricture and a large stone behind this stricture. And what he does is absolutely fascinating. He uses laser in order to dissect and cut the PD stricture, then coming back another day to go beyond that stricture, then dealing with this PD stone, sweeping it out, and then pretty much allowing this patient then to become pain-free, right? So again, not to be done by everyone. Obviously, Dr. Shah is somewhere in this hospital, probably doing this thing right now. But what a powerful thing to be able to do for a patient, right? Instead of taking them to surgery, right? Being able to use laser to cut through a stricture to deal with the stone and then allow a patient to be pain-free. So again, this is the PD stone now getting laser lithotripsed and then getting swept out after. So a couple tips and tricks when doing cholangiopancreatoscopy. Again, you want to rock in with, when doing biliary cannulation, you want to rock in with primarily with your big wheel, angle the tip of the cholangioscope to mimic a sphincter tome. Once in the duct, depend primarily on the cholangioscope wheels for directional flexibility. Some of the newer devices that you may see here today have different features that don't have wheels in it. So look forward to you guys playing with that technology. Drive the duct up with the wheels unlocked or any of the handles unlocked. Use fluoroscopy if you have any resistance. And then you can, once you're in position, you can semi-lock the wheels or you can lock the handle in order to get yourself into place. And when if accessories are getting stuck, that is less of an issue now that the channels are bigger. For introductory cases, when you're doing this as the first time as an attending, you want to start off with ductal clearance, pathology in the mid-CBD, and then soft stones. Do not please start doing a Rajah technique on your first month after graduating and as an attending. In conclusion, there's a solidified role for cholangiopancreatoscopy in both the diagnostics and therapeutics. The future of cholangiopancreatoscopy is very exciting. So cholangioscopic directed resection of biliary tumors, we're starting to see some of this work coming out of Asia. Cholangioscopic gallbladder therapies, improved imaging and artificial intelligence, as well as an increased diversified accessory portfolio. And with that, I thank you and appreciate your attention.
All right. Thank you, Dr. Fan. That was an excellent talk. It is my pleasure to welcome Dr. Eric Montminy to come up. He is now at University of Chicago. He is one of our former fellows. We are so proud to have him back here, and of everything he's achieved, we'll take all the credit. So welcome, Eric.
Hello, everybody. I just, again, I want to highlight for all the fellows in the room, really take in these next couple of days. I remember when I was a fellow attending this conference and just being blown away by everything. So these next couple of days are for you. So and I love this stuff because you continue to learn stuff even as an attending. Like Dr. Law showed about that saline injection in the tick. That was awesome. I never had seen that. I also like his kind of Anchorman moment. It was like 60% of the time, it works 100% of the time. But I think that's awesome. So take it in and just know you're going to learn stuff and it's going to be a fire hose, but it's going to be the birth of your intelligence in this awesome, cool field. So I'm going to give you some hot takes on diagnostic US. I've kind of made this more directed towards the fellows, so I may bounce around a little bit on each slide, but it's more to just get you the highlights and pearls. I'm going to try to teach you everything about EUS in about 20 minutes, so bear with me, okay? So I have no disclosures. I have some objectives for CME, but diagnostic EUS. So for really doing a high quality EUS and really in general, any complex endoscopy, because that's what you all are going to be doing now, you really must, one, know your anatomy. And I really believe seeing is believing. So actually like seeing the organ in your head, understanding the three-dimensional appearance of the organs that you're trying to look at, because then you can really then take it on to understand where your probe of your ultrasound needs to be in relation to your scope movement. With that together, that helps you kind of further understand the shape and how you need to move purposefully and smoothly to better visualize what you're trying to diagnose. What are the things you're trying to do with diagnostic EUS? You're going to be asked to stage tumors. You may be asked to look at subepithelial lesions. So looking at that GIST, finding that carcinoid, or making sure that that lump in someone's stomach is just a lipoma and they don't need to worry about it anymore. You are going to be asked to often stick a needle into something. Whether that means to obtain like a core biopsy or slurp some fluid out of a cyst. Someone's going to be coming in with pain, and in the right upper quadrant, you're going to be asked to Make sure there's not a stone lodged in a very delicate duct. I think often you're going to be asked to weigh in as well about patients who are really suffering from pain of the abdomen and making sure that they don't have any evidence of underlying pancreatic disease, being a cancer, someone with evidence of chronic pancreatitis, a stricture. Dr. Fan showed beautiful images of evidence of IPMNs in the duct. You're really going to shape the trajectory of these patients' clinical care. I would say overall, most often diagnostic EUS is really shifted towards a linear exam. So we have two basic, for the fellows in the room, two basic echo endoscopes. There's a radial and then there's a linear exam. Linear is going to be your workhorse for now, but don't forget that radial still is involved, okay? So I always start off with understanding, especially when I'm talking and teaching fellows, is that the scale is so important, particularly on your left hand. So to now, you've been doing EGDs and colons and deep enteroscopy and all that stuff, and you've been on the like inches to feet scale. Some of you are just flying through the colon, so you're really just like going at it with the, you're flying through 2 feet of colon right away, right? But now you need to drop down to like the centimeter and more likely the millimeter scale, okay? And it's not just what your body, it's actually everything you need to be on the millimeter scale. So that involves like your big wheel needs to be on the millimeter scale, your little wheel needs to be on the millimeter scale, torquing needs to be on the millimeter scale, pushing in and out, everything, whether it be torquing with your elbows, moving your waist, everything needs to be slowed down and shrunk down, okay? Left hand control really is critical because it will be actually dictating most of your views, but your right hand really can help now with stability and really spinability. How many people in this room, over the last 2 years or 3 years are going home every day just like, my hand is burning right now because I've just been cranking on this, my right hand so much. That has to go away, okay? Now we need to be looking at how can I use my right hand to move it a little bit to aid my left hand to see this very critical view, maybe right where the ampulla is showing the biliary orifice and the pancreatic orifice to roll out a stone. And the last thing to really understand is you're inverted now, okay? Left is right. Your movement of your left hand towards the right means you're swinging towards the left and vice versa. So I like using the mantra as slow, small, smooth maneuvers. This can really help you just bring in something into view and not get chaotic. I remember when I was learning EUS with Anna, it was just like, she was like, you're in La La Land. You're in La La Land right now, okay? You need to slow down, just focus right now. So often, if I have one starting the main tips of Montmany's tips, okay? If you can't get something into view, just slow down, small maneuvers, and shrink down your scale. You can often find what you want. Body position is vital here. So how you stand next to the patient is critical, okay? So until you reach the duodenal sweep, you should be in a neutral position, like kind of how you are during your EGDs. You should be perpendicular to the bed. So you can see, when you're in the esophagus, the stomach, the bulb, your patient is lying on the bed and this arrow is indicating you should be perpendicular. Once you hit the sweep, you're going to be you're going to be switching now to the ERCP position or parallel to the body of the patient, okay? This is really important because it's going to help you stabilize your scope so you're not flying all over the place. It's going to optimize turns off the midline, which you're really going to be having to do often. You're going to be, like I said, minimizing the amount of time you're going to be getting lost or going into La La Land, okay? Also, my fellows in the room right now, I will hammer away at how important this staying in these critical positions is important for your ergonomics. Your wrist health is so important to what you're doing right now. And it's going to be essentially your career, and your wrist should be utilized the least over this career. And optimizing your neutral positions throughout EUS is going to basically keep that wrist lifespan as long as possible. So let's just go into some stuff, okay? So tumor staging and subepithelial lesions, it really is essential for when you go into these diagnostic procedures that you just know your critical, your staging criteria and your wall layers. You just have to commit these to memory. Luckily for most luminal diagnostic exams, what T2 and T3 and T4 and T1, all those are going to be pretty much the same. I always, when I'm looking at this, I had to make this simple. I'm not the smartest guy in the room, okay? I'm not Einstein. But I had to shrink this down to make it easy for me. So I looked at muscle layers and subepithelial layers, and I just said, that looks like an Oreo cookie or an ice cream sandwich. And so I always look for that. And that's kind of where you go from to make the rest of your exam and kind of reorient yourself during these diagnostic staging and subepithelial layers, okay? So looking for that Oreo cookie can help you know where your propria is, your subepithelium is, and your muscularis is. The majority of these exams are going to be done with a radial exam. It can be done with linear, but really this is where your radial becomes the workhorse. What I do recommend as far as my tip is, try to minimize how much balloon you do. You can really upstage a tumor on accident. And I'll show you an example of that. If you have too much pressure on the lesion. So here's an example of an esophageal cancer I was staging. You can see this has got very minimal amounts of pressure on it. I can really nicely define out the muscularis propria where my arrows come. Can you guys see my arrow? Sorry. Muscularis propria right there. The serosa is intact, and you can see this kind of just ill-defined mass right there. Okay, moving along. This is an example of overinflation, okay? So I have GJ kind of just going into the fundus mass right here. You can see it kind of right. Let me go over here. This is the mass, and this is the liver, okay? And I'm actually concerned that the mass is encroaching on the parenchyma of the liver. So concerned about a T4 mass because just for our prognosis. So what did I do? I kind of eased up on my big wheel. I brought down my balloon a little bit and I started to actually see some tissue layers. And so this was actually a T3. So moving along. Okay, I know I'm kind of bouncing around a little bit, but now FNA and FNB, okay? So this is going to be probably, as far as diagnostic stuff you do, is the most invasive thing. You're throwing a needle into something. You're going to have different needle sizes that you're going to get used to, primarily a 19 gauge, a 22 gauge, a 25 gauge. I think you're going to find which one you like, okay? Most people will kind of orient themselves towards the 22 and 25 gauge. Larger bore does mean increased trauma, and that makes sense. So your 19 gauges are going to put you at risk for more of an injury, but really don't be afraid, okay? These are not sky-high complication rates when you throw a needle into something, okay? It's vital that you keep the needle in view. I think that kind of goes without saying, right? And I know that sounds obvious, but you'd be surprised how many people I've trained or whatever, and they're losing the needle and they're throwing actuations. And we have the hepatic artery or the celiac artery right in view, and you're throwing a 22 gauge trying to biopsy a lymph node. So keep that needle in view. I think FNB, overall has shown superiority for acquiring solid tissue acquisition compared to FNA as far as my experience goes. There's been prior studies that, kind of argue, maybe if there's not that much difference, but when you're really trying to get a nice core, FNB is just, you're going to get your nice diagnostic results that way. Large cyst, I do recommend using a 19 gauge. And then why is that? It's because, mucus fluid, as you saw in Dr. Fan's, fish mouth video, it's goopy. It just will not get through a needle fast. So unless you have an hour and you want to sit there and suck it through a 22 gauge, 19 gauge, just going up that little bit of amount of diameter, really will save you some time. 19 gauges, we have the, intra cystic biopsy, if you do believe in that. It's had some earlier, when it was first coming out, some good results. You do have the concern for, increased risk for pancreatitis with it, but the 19 gauge does give you that option. Doppler can be left on the whole time during this, but it's a trade-off. When you put on Doppler, the quality of your EOS will go down because it's being redirected towards the vessels and highlighting those. So you do have that trade-off. So if you have a really poor defined lesion, it's important to know that, you can leave on Doppler and have that safety net of being able to see where the vessel is all the time, but you may be dropping out where the borders of a poor defined mass could be. So I do like it because you can see some reflections off the needle sometimes. So I can sometimes see where my needle is as I advance it. When you start getting very good at FNA and FNB, you really get a feel for what you're sticking your needle into. And so it's not as much of an issue, but I sometimes will show that to fellows when they're first starting out, just to really see when you're doing an FNA or an FNB 3 centimeters into a lesion, where you're seeing a little bit less quality. You can see that reflection off your needle. Slow pull, stylet, suction, data's kind of mixed on all of this. Some people say none of it matters. There's been plenty of meta-analyses on this stuff. I think most centers will just stick to a protocol. I think of all of these, the kind of thing that surfaced the most is suction will cause more trauma to your sample. So like a nice soft goopy lymph node can come back pretty bloody. But stick to a protocol, see what works for you. You're going to find your niche. I think really just as far as what you do during this, whatever technique you do, the most important thing is just really staying within the lesion as you throw your actuations. The other big thing I would say with FNA, FNB, just glucose. This has been a really cool thing that's come out. Some people like, sending it to their lab, and it can be a little bit cumbersome that way. You can actually, I remember when I was a fellow here, we would just grab a point of care glucometer from PACU and just, if you could get the sample to go in, you could get some evidence of if the glucose was less than 50, you would be concerned that that was a mucinous lesion. The only thing is you have to be sure it's not goopy enough, and so you can get some, wasted sample. So here's a nice video of me. I hope this works, but of doing a perihepatic or a hilar, a lymph node, and just really showing both the reflections of the needle and staying within the node the whole time. So there I am. I'm using it. You can see I'm right next to the hepatic artery right there. And so I'm wanting to see my reflections off my needle. You can just see it the whole time, right? And I'm staying and I'm in the lesion the whole time. I'm spanning the lesion as much as I can. This luckily was benign. It was unfortunately in a 19-year-old who had cholangiocarcinoma later on cholangioscopy. So this is what I love this conference, is our talks all meld together. All right, moving on. Okay, so this is everything you need to know about Diagnostic US. It's a ton of things, right? And we're going to go through all of this. Just kidding. No, but I'm going to highlight some of the main things on each one. But these are the things that you're going to be looking at throughout every single exam in one way, either actively or passively, right? So as far as the esophagus, this really is your esophageal exam. But if I had to pick out one thing from the esophagus, I would really focus on the mediastinal stations during most of your exams. Why is that important? Is because you're going to have to get really good at staging something called esophageal cancer, okay? And one of the most important things that surgeons, particularly thoracic surgeons, want to know is, do they have any evidence of mediastinal disease, okay? So it is essential that you are able to get good views and get good at visualizing the subcarinal space and the aortopulmonary window. And then that sounds really crazy. You're like, no, I'm not an interventional pulmonologist. I don't do mediastinum. I don't want to look at the chest. I'm not an echo expert from cardiology. I'm a gastroenterologist, right? I don't want to send them I don't want to learn TE, but it's actually really easy to look at this stuff. So the easiest way is just find the IVC from the stomach and just start pulling back. It's almost a linear shot. And about at the subcarina, you're going to be at about 30 centimeters from the incisors. And then in the AP window will pop in around 25. Why it's really important is because even in not esophageal cancer, this is something I learned from Raj, Shah. He was like, you will find something here. My personal find since being and attending, I have found incidental lymphoma. These are on cyst cases, by the way, pancreatic cyst cases. Okay, every single one of these, I found a lymphoma. I diagnosed sarcoidosis. and thyroid carcinomas. Okay, so you will find stuff. It's not common, but you will find stuff. So here's a nice example of me doing the mediastinal stations. So I've found the hilum, I'm found now the hepatic veins. Here's the IVC coming in, and I'm just going to start pulling back, okay? So here is the subcarinal space starting to come in. That's the left atrium that's beating really well, and the pulmonary artery next to it, and the aorta kind of striping down. So you're going to see me freeze for a second, and I'm marking the subcarinal space. That where my arrow in the SC, that's where you're going to find those lymph nodes, okay? So now I'm going to pull over. You're going to see this artifact. That's the trachea I'm going across, and I've just pulled back. And now I'm seeing the aortopulmonary window. You can see these benign appearing nodes in that kind of same space, okay? You should be doing this every single time. This is where you're gonna find those scary things, okay? All right, moving along. Stomach time, okay? So again, everything's in the stomach. You're gonna spend so much time trying to learn this stuff. Everything seems hard, but it's something that you're gonna build up on as a fellow, and you're gonna be like, I get it. I get this little part now. I'm gonna build off of that. Now I can see the pancreas better, et cetera, et cetera, et cetera. And all of this is gonna start being put together. If I was to pick anything of the stomach, it is so important that you understand the splenal portal confluence, okay? This is on top of the celiac artery, and the take off the axis. This is probably the most important landmark for you to know. It's really a home base for both the stomach primarily, but also the duodenum, because it's going to primarily orient you towards the pancreas and specifically the genu and neck. This is going to be, the majority of your diagnostic exams, right? It's being able to look at the pancreas, but it will really kind of guide you, and it's big, and it'll be able to help you find sometimes these fatty pancreases that you can't see really well. So if you can pick up the confluence, you can often start picking up the pancreas. And from there, you can pick up your cysts, you can pick up your whatever, your lymph nodes, okay? So I like using the splenal portal confluence because it's such a centered port of my exam that it can help me see if I can even reach something on FNA or FNB. So a surgeon or an oncologist comes to you and is saying, hey, can you poke this thing for me? This patient has got a positive PET in this. I almost always look to see where it is in relation to the confluence. Because it's really the kind of target range. It's within the ballpark of where you can reach often. And what's really important is that it helps orient you anatomically as you advance your scope. So remember, when you go from the stomach to the duodenal bulb, you're going to rotate around the axis of this portal vein. And what does that do? So if you look, here's me, nice and bilious. You're right here in the stomach right now. As you go into the portal or into the duodenal bulb, you're going to make a march. You're looking initially down this way. And so your orientation on your view is going to be in this direction where the portal vein is going up to the left, the splenic vein is going towards the right, the SMV is going down. You're going to go swing around, and your view is going to be moving this guy to right here. And so now your view, when you're in the duodenal bulb, these two, this SMV and SMV, have flipped around. They spun around the axis of the portal vein. The other way to think about this is your head of your pancreas. All these lesions that you're going to be looking at are going to be always nestled in the portal, between the portal vein and the SMV, okay? So that's why is that important on diagnostic EUS? Because you're going to use that SMV to help you find the SMA, okay? So you're going to be looking at pancreatic head masses and biopsying that. Why is an SMA very important? It's because that is going to make something a T4 lesion. It's going to be something unresectable when they have invasion into that. And so that SMV is very important for you to look for because it's going to help you orient towards the SMA, okay? Moving along. So you can't find the pancreas. You can often find the splenic vein or the confluence to help orient you. Losing my thing. Okay. Here we go. All right, so the pancreas, right? This is going to be everything, right? This is what EUS is today, is looking at your pancreas. So a pancreas is really shaped like an upside down Nike swoosh, right? And you need to make that motion with your EUS scope. So remember, understanding the shape of organs, that's how the probe has to move. Okay, so you need to make that same swooshing moment. I'll show you that in my next slide. So as when you try to visualize the entire organ. It's so vital for you to trace the pancreas out. Don't just take a snapshot. Don't be, doing your 5-minute EGDs, okay? You need to spend the time to look throughout the entire pancreas. Why is that important? Because you will miss lesions if you do not trace this all the way out to the spleen. Sometimes the pancreas doesn't go to the spleen. That's a hallmark of pancreatic atrophy. You'll see that with chronic pancreatitis, but you need to trace that all the way out. Otherwise, you will miss stuff. You can also miss things like splenoles, all sorts of things that are in that peripancreatic area towards the end. Like I said, the easiest ways to find this probably is, as you're learning, is finding from the celiac axis, and I'll show you an example of that. But also, don't forget the confluence. You can find this by tracing back the splenic vein towards the confluence. At the confluence, you'll see mostly the genuine neck sometimes, and really robust glands. You'll actually start picking up the head. You'll be able to see some of the splenic artery and vein. Like I said, the SMA uncinate will be your primary anatomic landmark for the uncinate. Bounced around really. The splenic artery and vein will be helping you be a landmark for the body and tail. So remembering that the body and tail will track out with the splenic artery and vein. So that will be something for you to know as well, as far as orienting the pancreas. It is very important as you do FNA and all that stuff, not to hit the pancreatic duct. I think that goes without saying. You don't want to leave sampling assist and with a pancreatic duct leak, okay? So making sure you're taking your time to orient yourself, see the gland, and see your needle when you're advancing the needle into the gland, okay? Here's basically that Nike swoosh that you're going to make. So when, you guys are used to looking at EGDs, right? So this is greater curvature, lesser curvature. There's the heart beating. At the liver is going to be mostly up here, okay? And this Nike swoosh you're going to make on average-ish, you're going to be seeing the neck, a little bit further down. And then you're going to be pulling back as you make that Nike swoosh sign, okay? As you get closer and closer, you're going to pick up the body towards the tail, and you're going to be getting close to the cardia and fundus. You're re-hitting the spleen. What does that look like, okay? Here we go. So here I'm at the celiac axis. I pushed in just like 2 centimeters. I'm at the pancreas and I'm at the confluence. This patient had a lot of portal hypertension. So you can see this very robust confluence. And I'm just scanning over the confluence right now. And you can see right here, waterfall sign. This is the pancreatic neck swooshing down. You can actually pick up a little bit of the pancreatic head. And you're going to start seeing me soon track out, here's splenic artery and vein. So I know I'm near the body. And I'm now tracking this out. And I'm scanning. I'm not just advancing my probe. I'm rocking back and forth to pick up anything, okay? And so I'm going to keep tracking this out. I'm going over the left kidney. And this patient, you can see, had tons of splenomegaly. And here I am picking up the very end of the duct and the tail. And there's the end of the pancreas. There's the splenic hilum, okay? The other thing you can kind of use as your landmark for the end of the pancreas sometime that you know is coming near is those like kind of bullet holes of the splenic artery and vein. They're going to change orientation from being nice and round to being a little bit more linear and kind of turning their orientation a little bit. So you can see they kind of went a little bit more linear. Liver. You're going to find this pretty much throughout most of your exam, obviously not in the esophagus. I hope not in the esophagus, but you're going to find it mostly in the stomach. In the stomach, you're going to be looking mostly at the left liver. In the right liver, you're going to see a little bit of the hilum in the duodenal bulb. You're going to see that in mostly the right liver and some of the hilum. But the majority of your exam, you're going to be picking up in the stomach, and it's going to be mostly your left liver, okay? I think with my liver exam, when I'm doing diagnostic exams of the liver, I'm looking mostly at the texture of the liver. And it's primarily based on blood flow. I think a lot of you have learned that probably already, that the kind of old adage is that it should be similar to the kidney and spleen. And if it's brighter than one of the, being the liver, being brighter than one of those, you could suspect some type of underlying chronic liver disease, most commonly fatty liver. But it's really it's really important that you, just like with the pancreas I showed you, that you should be rocking through this to scan, because remember, ultrasound is just a slice okay? And you need to recreate all these slices into a three-dimensional object, okay? So you must lift your left hand and drop your left hand as you push and pull back to actually see and scan through the entire organ. If I was to pull out anything from the liver exam from diagnostics, the main teaching point is that metastatic disease can look however it wants, okay? And when you're looking at this and learning how to pick up a hepatic met, you're really looking at like disturbances in the uniformity of the liver. And one of my best friends from college, I use this example with my fellows. He is a video editor, and the one show he was contracted to do was Cops. The old show Cops. And they would blur out their faces, or their mouths. That's what you're looking for. You're looking for that swear word the liver's saying right now. Okay, but the big thing is Mets can look however they want. They can be hypoechoic, hyperechoic, and I'm going to show you an example right now. So I'm showing you Mets. This is like the leprosy. That looks like obvious looking Met, right? Obvious looking Met. Obvious looking Met, right? You're picking up all these. One of the largest Mets actually is right here. How many of you actually, raise your hand, saw this Met right here when you first saw it? Probably none of you, right? This is the hallmark that you can see. It can look just like a little disruption, okay? Here's another one. Looks a little hyperechoic right there. But these obviously are really big hypoechoic. This is a beautiful example that I saw. So what do I mean when I'm scanning the liver? This is, I want to show you guys, this is a nice view of kind of hepatosplenomegaly sign when the liver and the spleen are touching. And so I'm scanning the liver. I'm making big swings. And there's the spleen, giant spleen touch. You could see the differences in the color and or the blood flow between the two. So you know that liver doesn't have like a bunch of fat in it. But I'm going over the hilum. I'm swinging back and I'm going all the way proximal as I pull back to the heart and making sure I'm seeing all the way up the whole left lobe. Okay, so don't just pick up the liver, take in a sign or a picture, and I'm moving on. Okay, really, you will pick up incidental findings. It's very, very vital. You see that whole organ. Sorry. Okay, duodenum. Again, smattering of things that you need to know. Okay, this is probably, as fellows, probably the hardest thing you're gonna need to learn. Okay, it's just a big learning curve that you're gonna have to jump. Of it, obviously, the bile duct and the ampulla. It's really the primary portion of duodenal exam, except the head and the uncinate. But like I said, this is the steepest learning curve. So really just the best way to learn this is just set yourself up for success. The biggest step I learned about this, how I learned to get good at this, is don't go into the duodenum with a headlock on the scope, okay? If your body's in a weird position, you need to take a moment to really reorient yourself and say, okay, I need to get neutral again. Remember, I said, until you hit the sweep, you're not in ERCP position. You need to be in EGD position. So go in, neutral hands, you're on a serving platter with your hands, and just pop in like you would with an EGD scope, right? At that point, you're pretty much going to be a little bit oriented a little bit towards the right liver, but as soon as you start going clockwise, you're going to bring into the vital organs that you need to do your diagnostic exam on, okay? And that will be your confluence, the head of your pancreas, and your bile duct. Test yourself when you're learning this, okay? See if you can trace things back and when you're in this very tight area. Take that 5 minutes that your attending allows you to do to play around and see if you can track down the bile duct all the way down to the ampulla and all the way up to the bifurcation, okay? Obviously, you're going to be using this portion of your exam to look at stones, okay? So you'll see a big giant dropout. Sludge won't often be a dropout, but it can. Depends on how much calcium is in there. The other big thing I would say as far as diagnostics in this, if you suspect cholangiocarcinoma, do a diagnostic EUS up front. A lot of times you can pick up lymph nodes in the perihepatic space or periportal space that may make your life a little bit easier when you go to want to do a complex ERCP or difficult ERCP with someone with a really tough hilar stricture. Going in knowing you already have a diagnosis can make the length of your procedure a little bit shorter, less anesthesia for the patient, less dilation, all that stuff, all that, you can make your plan a little bit more streamlined, okay? Alrighty, moving along. Here's a nice view of a diagnostic exam I was doing, ruling out a stone actually. But this is me setting myself up for success, okay? Entering in a neutral position. So I'm entering into a neutral position into the bulb. You can see the pancreas still. It's coming in, boom, I'm right at the confluence in the pancreatic head, right? So I'm already at the pancreatic head. All I need to do is start rotating clockwise. I'm already bringing in the bile duct right there. I'm getting great views of the short axis, what we call, and getting it all the way down to the ampulla. Okay. And here's me now testing myself, bringing this bile duct all the way back up towards the bifurcation. Okay. So small purposeful movements. I'm keeping the bile duct centered as much as I can. I'm bringing it up towards the confluence. And there I'm at pretty much the end where I can see before start getting a little bit of dropout, but you can start seeing the right liver. So I've looked at most of the main duct right there. All right, so moving, man, this need a clicker. Okay. Long axis is the other part of this. So this is your D2 exam. This is the most awkward exam. Sorry. All right, I'm wrapping up. Okay. You're like, hurry up, play me off. Most awkward part of your exam, D2, you're going to be in ERCP position. You're going to be pulling back and going counterclockwise as you torque, okay? It's very important because you're going to be assessing the SMA. You're going to see any type of involvement of a pancreatic head mass or an uncinate mass in this position. And what you're going to be really doing is rolling off the SMA and SMV to see the uncinate and the ampulla in a different position. You will miss stones in the CVD if you do not do this portion of your exam. Don't just focus on ruling out your exam, your stone exam in the bulb. And why is that? Because you can actually pick up the intraduodenal portions of the biliary orifice. So you can see here, I'm at the ampulla. This is the best place to start. And you're just going to push in from here, switch over, suction down. And I'm already starting to pick up the mesenteric SMV and SMA a little bit. You're going to see me start picking them up here. And I'm going to now roll off as I pull back right here. And I'm starting to pick up the uncinate right now. Right there. And now I'm pulling back a little bit more as I keep rocking. And I'm picking up now the pancreatic duct right here. And I roll a little bit more, and you're going to see this nice view of the bile duct and the pancreatic duct snuggling up together, okay? So that's why it's really important. And I just wanted to show you some good views. Here's a nice, beautiful view of actually seeing the duct penetrate through the intraduodenal portion in the lung. And this is a nice view of a stone that was found not in the short axis, but the long axis. So my conclusions, it's a learning curve for y'all, but it's not just your medical knowledge, it's your body and your motion learning curve. You need to like reorient your brain and learn these kind of techniques for hand-eye coordination. Remember, neutral position will go a long way with optimizing your diagnostic exam. Know your key landmarks. It's important to scan objects. And if possible, always view everything in multiple axes to help you misinterpret or not misinterpret anything. Thank you. Sorry, did I go over?
Thank you so much, Eric. That was excellent. So we are going to plan to do 10 minutes of Q&A now. Then we'll take a 10-minute break and we'll start back with lectures at around 10 o'clock to keep us on track. I want to invite all the faculty to sort of participate in the Q&A. So we'll walk around with a microphone. So if you guys have questions, just raise your hand. We'll come to you. And if not, I can start off with a question. Do you guys have any questions so far for our presenters? Okay, I can start with one. So maybe we'll do rapid fire just to keep it quick while the fellows think of questions. sort of to tell the trainees or give them a perspective from all of the different attendings we have here, how quickly, think about Ryan's talk, if you can't get access into anything, how quickly are you moving to freehand needle knife or doing a pre-cut? I think some people say in these talks they go very quickly, but in reality, oftentimes people futz around for much longer than they'll admit. So I think it's just helpful for the trainees to the honest truth here, not the presentation truth. How quickly are you guys moving to that? How long will you give it before you're trying that?
I would say I probably try a little bit longer, but the key for me, and I think this changes over time, is the more cases you do, I think the more you understand whether you're really going to get in or not. I think you start to have an understanding of, what, I don't think I'm going to get in doing kind of conventional things. So I think over time you do shorten it up, but I really believe that as long as you're not, completely macerating the major papilla, I don't think it's unreasonable to continue to try. If you're starting to get some edema, um, or if you think that you really aren't going to get in, then it's time to make a change. What I would say is that I probably I'm not a big proponent of changing to a different catheter or different wire because I feel like I'm pretty confident and comfortable with the setup I use. So I would go directly. Personally, I would go from what I start with to a fistulotomy or a pre-cut. But I'll definitely give it a try for a while.
Those were all excellent talks. Eric, I love the upside down Nike swoosh. Jennifer, I love the AI to really help us with targets of biopsies. And Ryan, I was around for the compact discs as well, so you're not alone. But my question is for you, Ryan. So just a comment on what you just said. One of the things I always tell the fellows is never repeat the same movement twice. So if you're doing the same thing over and over, you want to separate yourself from a monkey. A monkey can do this, but what differentiates us is to think and to do something different. So if you're finding that you can't do anything more with the catheter, I completely agree with moving with the needle knife. One of the things that I've noticed, and I'm curious to your to the entire panel's experience with this, is when I go for a needle knife, I actually start at the ampulla. I don't go for the fistulotomy, but what I tend to think of it as a mass is typically, or an obstruction is typically pushing the bile duct. So I have to move more towards the 12 o'clock position as opposed to the 11 o'clock position. Any thoughts, experience, comments on that? And have you done the same, or are you guys sticking with the 11:30 spot?
I agree completely. I think it moves a little bit towards the 12 o'clock position. I think you adjust the swing based on how it looks on your initial cut. Obviously, we don't want jagged Halloween type cuts, but I think you do need to position yourself more at the 12 o'clock position, or an impacted stone also pushes it towards the 12 o'clock position as well. I agree with Ryan. I give it a shot. I think if I get into the PD twice with the wire, I'm going double wire technique right off the bat. I think there's very little downside to going double wire technique, and then I'll give it at least 15, 20 minutes of a good try. If the fellow's hands are on it, maybe like 6. But but you give it a good shot before you try to do these advanced techniques, because the issue is that if you have bleeding, you have no access. You have no way to salvage unless you want to switch really quickly to a now higher risk technique, which is like your EOS guided techniques. And so you want to give it a good shot.
I have one comment and one question. The comment is, I think, Eric, you need to disclose if you have shares in Nike next time.
Oh yeah, so there's a new shoe line coming out, so look out.
Having said that, I do have a question. Who uses the 15 touch or 5 cannulation attempts for the fellows in order to then move to the staff? Because that's done in many places and is also done for randomized trials to try and homogenize the approach, which is so difficult to do. So I was just wondering, because I'm sure the fellows here live with this and they should get an idea that there are some data to support it, but I just want to know who uses it.
I don't. I give the fellow until I start seeing perspiration, usually, or if I just don't sense a good confidence in in their approach right now. If they're all over the place and they're having trouble stabilizing, I'll give them a couple cracks at it. I think for attendings in the room, giving the fellow one more shot is key just be like, I want to give go ahead, give it another try. Because I think that does give them a little bit of a morale boost while you're putting on you're accentuating your gown opening for them to hear. But giving them another try just gives them another little morale boost in these difficult papillas. The one thing I would add to all this discussion about needle knife, the other big thing I would say is if you're starting to lose delineation of the anatomy, we start making this look like mincemeat, that's something we need to kind of keep in the back of our mind, like, okay, maybe needle knife is not the right approach. If like just what Dr. Fan had just said, that if you have a complication with this, you're up a creek. I'm not going to use the word. Okay, and it can get you in a real mess. Okay, so knowing what your limits are.
I think giving fellows a shot is extremely important, but I think we also know as an attendings which are the higher risk patients that really should follow the more conservative approach for fellows, right? Female, really young, right? Giving them too long of an opportunity can start to become a little bit more unsafe. So I also agree, giving fellows a really good shot at getting in is so important because then they learn the movements that get them there and got them there. But there are certain patients
Absolutely.
where safety is an issue.
I think outside of any sort of trial we're doing, I don't keep track of where they're at. I do think over time we develop a sense of, can you legitimately talk them through this, regardless of their skill level, first day or last day? Can you give them some guidance that they're going to succeed? And is that paired with good technique, keeping the papilla in reasonable working order? I think from the fellows in the room, when your attending takes the scope, I would make 2 points. One point is sometimes if it seems early, it might be because they know it's going to be hard. So I have a good sense of what I'm looking at. Like, this is going to be hard. So that's one thing. The other thing that I would encourage all of you is to not be discouraged by that fact. There is. It seems discouraging, but it's really not. And I think that one thing that as a fellow, it's hard to appreciate is how much you can learn by watching. You can learn a tremendous amount by standing next to your mentors, watching their hands, watching their body movements, watching their eyes when they're looking at flora, when they're looking at endo. In just what they're doing, you can pick up a lot of things and a lot of important things that will help you in your career. So instead of being discouraged that you're never going to figure this out, you're not going to get any better, that's one thing that I would encourage all of you is be really proactive at taking the time, watch what you're doing. The other thing in that time, if you're at a point where you feel reasonably comfortable with what's going on or what your attending is going to do, use that time to understand what your nurses and techs are doing. You should be able, as the attending or the fellow in the room, to set up the room, to set up all the equipment, to be able to do exchanges, take FNAs, whatever it may be. Be comfortable with all of the equipment. You can't expect the people that are working with you to know stuff and do stuff that you don't yourself. That's my general feeling.
Just real quick to add to that, when I was training, I videotaped the first 50 cannulations that I did. Because the most frustrating is you're like, well, I did that. Like, how did the attending get in like 2 seconds? Like, I did the exact same movement. The papilla just spoke to the attending better. And then you watch your video and you realize, dang, my movement was so jagged and my little movements were so exaggerated. It actually really helps your education more than listening to your attendings, because now you're like, okay, I took what they said. I can see why I didn't get in. And then that learning curve gets so much shorter. So I do this for my fellow. I did this for all my fellows at USC. Videotape all your cannulations and see why it didn't translate for you. And if they took the scope, why it translated for them.
It's so important to watch film. You look at Tom Brady, all these great quarterbacks, it's because they studied what they were doing. So take the time to watch some film on yourself.
I have just one quick comment and question. First, thank you all. Amazing presentations, Ryan, Jen, and Eric. It's all amazing, and I like what Ryan started with is that big part of what we do is personal experience, and many of the studies cannot be kind of calibrated for every single operator. And when I trained on ERCP, I was trained by Doc Plesko, and me and Bilal share the same experience. ERCP is like one of the most exciting procedures and remains to be because it's very humbling. Every patient is different. And about a month ago, we had Nagy already visit us in Cincinnati, and he gave a talk to the fellows about like evolution of ERCP. And he was saying one of the events he was celebrating his 10,000 ERCP, and he couldn't cannulate at that 10,000 ERCP. So it's so impressive. I think the key is the patience, and that's how we learned with Doug, is that after chewing gum and turning hard rock music on and calling Jermaine, who's our most experienced tech at BI, just to be patient. But I think also part of it is affected by how the ampulla looks and the indication for the ERCP. And that's something I want to get the panel's opinion about. That, like, sometimes when I go in and there is a good size ampulla and ample space to cut, and I'm not able to get in, I don't spend too much time. I know I have some space there to cut and it's safe, unlike when there is like this teeny ampulla that's right on the wall and I don't have much space. So can you give our group here your opinions about like how would the anatomy or location of the ampulla affect your decision on when to move to a pre-cut, and also the indication for ERCP, whether to move to pre-cut versus maybe EUS guided, for example?
Yeah, I think that's a good point. The one part that I'll take on is indication. I think that's really where you have to know when to call it. I had a case a month ago, small papilla, maybe a stone, double lung transplant patient. They were trying to decide if they wanted to take out his gallbladder. A question of a stone in the duct, wasn't seen on MR. EUS wasn't great. So the surgeon wanted an ERCP. Went in, couldn't get in. Did a pre-cut, still couldn't get in. Stopped. Not a huge duct for a rendezvous. And at that point in time, it doesn't make sense to take that risk. I brought the patient back 3 weeks later because he's doing fine. His numbers are fine. And got in. It was still difficult, but got in. And he did have a stone. But I think that keeping in mind your situation and your indication, you don't have to go all the way all the time. It's okay to stop. It's okay to regroup, so long as the patient's in a stable situation and you don't have to have, some outcome that day. But definitely keeping in mind your indication when you're doing all of these things. There's scenarios where you may try and cannulate and you say, well, I'm not even going to go to pre-cut today. That's okay. It doesn't have to be all the way all the time.
Great. I'm going to interrupt Eric since we have a fellow question in the audience. Go ahead.
Hello. Okay. Hey, sorry. I was wondering if you can comment on your role and approach to using cholangioscopy, specifically in tight post-transplant anastomotic strictures, and how quickly might you jump to cholangioscopy, or what your approach is?
Yeah, I think that's a great question. Sometimes the anatomy is so pinpoint because it's so strictured that really getting the wire across becomes very difficult. You do want to try a little bit, maybe change your wire a little bit, because the cost of doing it in a transplant patient with an infection is a little bit higher. So I'll maybe change my wire. I'll maybe use a thinner wire to get in, and then get my tome across before I go to cholangioscopy. So I would say for me in particular, I will get in, change wires, thinner wire, maybe a more like something like a VisiGlide wire to try to get through. And if I can't get through, then I'll go to a cholangioscope. But then remember, if it's that tight, it's going to be a struggle to get a lot of stents across and things like that. So access is extremely important in these transplant patients, but I would give it a little bit more time.
Yeah, I think it also depends on who your transplant surgeon is and how they approach their surgical approaches. So does your transplant surgeon leave a giant cystic duct remnant, and it results now in a hugely sigmoid new duct. And sometimes of the times I've used cholangioscopy in transplant, it's been when I'm just like, I have this giant sigmoid duct. It's completely blown out too. I'm just coiling. I can't make it to that pinpoint position where I can have pushability. And that's really, I mean, I rarely try to, same reasons. The infection rate is just a little bit higher with like a larger amount of instrumentation.
Thanks, guys. Any other fellow questions? Raise your hands. No? Okay. So to keep us on track, we'll take a 5-minute break and then we'll start back up around 10:05. Thanks so much, everyone.
All right, guys, we're gonna get started. Hopefully you had a nice break. Thank you for a great first session. So for our next session, it's a true privilege and honor to introduce Dr. Sham Tucker, who's a professor of medicine at West Virginia University, who was one of my first mentors when I was a medical resident. My first ever publication was with him, and it's been a true privilege to have him visit us at University of Colorado. And he's a true pioneer, innovator in the field, and he's going to talk about a topic very near and dear to, I know, all of you guys, all the fellows, creating new pathways, EUS-guided drainage, anastomosis, and beyond. So thank you, Sham. Yeah.
Thank you, Bilal, for that kind introduction, and thank you to the entire RMIE planning team for the opportunity for me to speak here today. It's an honor and a pleasure, and it's great to see all the amazing thing that's being done here at the University of Colorado. And this has always been kind of a premier advanced endoscopy course for the fellows, and I think it's a great opportunity for all of you. Bilal talked a little bit about how it transformed him, and I'm certain it'll have that impact on some of you as well. So I'm going to talk to you a little bit about interventional EUS. And as most of you probably know, EUS was first described in the 1980s, and linear EUS came on the scene in the mid-1990s. And interventional EUS actually became more mainstream as well, starting in the 2000s. But it was first described actually by Ken Chang in this paper in 1997 as an emerging technology of performing interventional EUS. And kind of since that time, it took us a very long point to get to that time, but now we've reached this age of what I like to call endless endoscopy, where essentially any procedure you can imagine can be performed. And I feel that that's especially true for endoscopic ultrasound. So the way I thought we'd walk through this is kind of talk about drainage procedures, do this a little bit in a case-based method, and then go through bypasses as well as beyond what we're seeing now through interventional EUS. So we'll start with pancreatic fluid collection. So here's a case, 48-year-old female presents after an episode of gallstone pancreatitis. You all can recognize the pseudocyst that's formed. And of course, as you're aware, different types of fluid collections can form after an episode of severe pancreatitis. This includes an acute fluid collection, acute necrotic collection where there's necrosis present, pseudocysts then can mature from an acute fluid collection, and then ultimately walled off necrosis from an acute necrotic collection. And so what are our indications for intervening? Well, certainly we don't intervene on all of these, but we do intervene on the ones that are causing symptoms. And this can include nausea, vomiting, gastric outlet obstruction, signs and symptoms of sepsis or infection. And for these reasons, we may perform an intervention. And so our interventions are various types. We can do transmural drainage, percutaneous drainage, transpapillary drainage, or surgery. And when it comes to transmural drainage, really EUS is the method of choice to perform this. It allows for safe intervention on these collections. Here you can see the use of EUS to place double pigtail stents in a pseudocyst. I think really the choice of technique really depends on the local expertise, but collections that abut the stomach or the duodenum are really best to manage with an endoscopic approach. And so here you can see after obtaining access, cooling a wire, using radiology to ensure that that wire coils appropriately, we dilate and then ultimately place our double pigtail plastic stents. And so, now we've had this lumen-opposing metal stent, of course, developed that allows us to do a lot more with EUS and transmural drainage in a much more efficient manner. Essentially, over 90 seconds, we can use the electrocautery enhanced tip, penetrate into a collection, deploy the distal flange, and then endoscopically deploy the proximal flange. When we compare transmural drainage essentially to transpapillary drainage, really, I think transpapillary drainage works best for collections that communicate with the main PD or 3 centimeters or less, but otherwise transmural drainage can work very effectively. And this was actually very well demonstrated in a randomized controlled trial by Bang and colleagues, where they demonstrated when they compared EUS transmural drainage to surgery, all these points were essentially better, significantly better when it came to procedural duration, disease-related adverse events, SIRS response, length of ICU stay, mean total cost with the EUS-guided approach. And as such, EUS transmural drainage has really emerged as the standard of care for treating patients with these types of collections. And so here you can see using the lumen-opposing metal stent, how we obtain access to a collection, and then under endoscopic guidance can deploy the proximal flange in the stomach side, and suddenly you get this large gush of purulent infected collection that can now drain appropriately and be very beneficial for the patient, of course. And so we were part of the group of the Destin trial, so direct endoscopic necrosectomy versus a step-up approach. And this was basically, using this lumen-opposing metal stent to access these collections, dilate the stent, and then immediately perform necrosectomy. And what we found was that, performing necrosectomy immediately can help reduce the number of reinterventions, can help reduce the length of hospital stay, and higher proportion of patients experience improvement at 72 hours as well. And so a trend towards lower costs as well. So as such, when it's appropriate, when the patient's stable enough, we try and perform necrosectomy immediately. And performing necrosectomy can be done with various types of endoscopic accessories, nets, snares, rat tooth forceps as an example. I tend to prefer a braided snare. I think that works best. But ultimately, once we get this collection decompressed or cleared out, these walls can then spontaneously collapse. So switching gears a little bit, let's talk about gallbladder drainage. Disease is primarily managed surgically, but there are non-operative approaches, and that can be done percutaneously or endoscopically. And the non-operative approaches are typically reserved for patients with multiple comorbidities, advanced staged, or severe type cholecystitis. And here you can see some other indications as to why we may prefer a non-operative approach, or the surgical candidacy might not be good. And so, the Tokyo guidelines were actually developed to talk about the different types of cholecystitis that present. And, it's really the type 2, type 3 that are considered the higher risk for surgical resection. And in these cases, we may prefer an endoscopic approach. Interestingly enough, the guidelines also suggest that PTC is kind of the first line, but, I'm going to show you some evidence why endoscopic approaches are now improving. And so some of the opportunities with our endoscopic approaches include the transpapillary approach using ERCP and the EUS-guided transmural gallbladder drainage. And so how does EUS gallbladder drainage work? Well, essentially, you can do this with double pigtail stents, self-expanding metal stents, or lumen-opposing metal stents. Lumen-opposing metal stents were actually approved for this indication in 2020 and 2023. And essentially for individuals that are poor surgical candidates with a dwell time of about 60 days, though we can leave them in indefinitely if we choose. Typically, I prefer a 10 millimeter lumen-opposing metal stent for this purpose, but I may choose larger if I'm going to perform a gallbladder-specific intervention. When it comes to technical success, it ranges anywhere from 95 to 98%, and it may be performed with or without fluoroscopy. And the puncture location really depends upon, from the duodenum or from the gastric antrum, really depends upon where you get the best kind of apposition, where there's no intervening blood vessels, where the shortest distance is. That's where I tend to prefer. There's no data to suggest that one is better than the other. And so when we compare EUS gallbladder drainage to laparoscopic cholecystectomy, what you can see is in this study, propensity match score analysis looked at 1 year follow-up. There was no difference in the outcomes when in terms of laparoscopic cholecystectomy versus EUS gallbladder drainage. So it essentially performed on par with lap chole. Additionally, when we look at ERCP, transpapillary gallbladder drainage versus EUS gallbladder drainage, we find that the clinical success is better as compared to transpapillary drainage. What about when we compare EUS gallbladder drainage to percutaneous gallbladder drainage and transpapillary drainage? Well, what we've seen is in this retrospective study, 372 patients with acute cholecystitis, the median number of interventions was less with EUS gallbladder drainage, and the need for additional surgical reinterventions was actually quite high in the percutaneous gallbladder drainage group and favored, again, EUS gallbladder drainage. And this network meta-analysis also showed the EUS gallbladder drainage as the preferred method of choice when it came to need for reintervention, unplanned readmissions, and recurrent cholecystitis. And so more and more, we're seeing EUS gallbladder drainage is becoming more mainstream in helping to manage these patients. Now, there's certainly the possibilities of contraindications. Here's an example of a gallbladder perforation. Patients can also have underlying biliary peritonitis, large volume ascites, significant coagulopathy, or anatomy can be an issue. And I think most of these are relative contraindications you can potentially salvage. I think the one that's really a definitive contraindication in my mind is a gallbladder full of stones. When you have a gallbladder full of stones, it's very hard for that lumen-opposing metal stent to open appropriately in the gallbladder lumen. And in those cases, I tend to shy away from doing it. But I think in these general areas, you always want to have a multidisciplinary approach to determine, what makes the most sense for the patient. So here I'll just show you another example of a patient with a perforated gallbladder. I showed you that image, had a locally advanced pancreatic cancer, and so had an abscess that formed intrahepatic. So after discussion with our surgical colleagues and IR colleagues, we opted to do this endoscopically with an EUS-guided gallbladder drainage approach. Here you can see the abscess cavity under EUS, and here you can actually see the fistulous connection. And so we opted in this case to use a 15-millimeter lumen-opposing metal stent because we thought perhaps we may perform some gallbladder intervention to irrigate out the abscess cavity. So using a lumen-opposing metal stent, here you can see the access, deploy the distal flange, and then ultimately deploy the proximal flange. And you can see the subsequent images of the purulent fluid that drains out. We can then just skip ahead, dilate a tract, and ultimately, I don't know if I can skip on this, but ultimately you can see the fistulous opening there. And then we chose to actually introduce a scope and irrigate that cavity out to effectively obtain clearance of that patient's infection. So she had locally advanced pancreatic cancer. She actually lived another 18 months with this stent in place, was able to avoid a percutaneous drain. And I think that's a real significant outcome for this patient because more than likely she would have required reinterventions for that drain. And on top of that, certainly the quality of life is not as good when you have that percutaneous drain hanging out. So in this ways, I think, these are kind of cases that you want to obviously have multidisciplinary discussions for, but where you can be impactful. Well, what about cholecystectomy following EUS gallbladder drainage? We've tended to believe that this theoretically is not possible, but a meta-analysis that was published not earlier this year, just actually in August, looked at 1,001 citations, 700 patients included, pool proportion 33% underwent laparoscopic cholecystectomy following EUS-guided drainage. And what they found was that 76% were able to undergo laparoscopic cholecystectomy, 14.5% converted to open, and only about 7% aborted. But this was only reported in one article, so we don't know if it was more or less. So we need more data on this. But, when we compare it to percutaneous gallbladder drainage, what you can see here is our numbers really perform on par with individuals that undergo interval cholecystectomy following percutaneous gallbladder drainage. So I think the more we get comfortable with this, the more our surgical colleagues get more comfortable with this, the more opportunity there will be to perform this as well. So switching gears, let's talk about bile duct drainage. Choledochoduodenostomy and hepaticogastrostomy are other ways. I'll show you here an example of a patient who presented with an ampullary mass. We couldn't identify the biliary orifice. And here you can see had a very dilated bile duct with mets to her liver. So we opted to perform an EUS-guided choledochoduodenostomy. And so here you can see the very dilated biliary target. In this case, I tend to prefer a 6 or an 8-millimeter lumen-opposing metal stent because the space is small. I want to ensure that I deploy that distal flange in the bile duct as best possible. I have enough space to do that. So here you can see the deployment of the distal flange, and then ultimately deployment of the proximal flange, and you can have obtain a nice choledochoduodenostomy there. One of the things to keep in mind is that things can go wrong with this procedure, and let's see, there we go. Things can go wrong with this procedure. And this was actually a case from our first West Virginia Interventional Surgical Endoscopy course. My colleague, Dr. Singh, was performing EUS choledochoduodenostomy, and there you can see very nice target, and he goes to deploy the lambs. And when he obtains access, unfortunately, the distal flange deploys outside of the bile duct, as you'll see here. And so in this case, now we've got a perforation in the bile duct, as well as bleeding. And this is never a good thing that you want to have in a procedure, but you have to be able to manage this and so perform salvage. So appropriately, what he was able to do was obtain wire-guided access to the bile duct, and then ultimately salvaged it with a self-expanding metal stent. Here you can see the cholangiogram he obtained, and then using a self-expanding metal stent, deployed it, the viable stent. This patient did great, stayed in the hospital overnight one night, and went home the next day with some antibiotics. So I think these are the kind of thing, if you're going to venture into this world of interventional EUS, you have to be prepared to salvage, because you're going to have complications. There is a learning curve and a mastery that comes with any of these procedures. So let's talk now about bypass. Bypass is now emerging, as well as opportunities for us to perform procedures or interventions with EUS guidance. So here's a case of a patient, 80-year-old female, who presented with gastric outlet obstruction after a diagnosis of pancreatic adenocarcinoma. So what are our options in managing this? Well, certainly one of these options is performing EUS gastrojejunectomy. And on Saturday, I'm going to be debating Dr. Binmoller on enteral stenting versus EUS GJ. But here you can see essentially what we do is flood the downstream jejunum with contrast and dye, and then ultimately use that as a target using a EUS to deploy a lumen-opposing metal stent from the stomach to the jejunum to effectively create a bypass. Now, one thing to recognize here is this is not an anastomosis we are creating. This is a fistula that we're creating. But it can work very effectively, and the data to date has demonstrated that you can have. There's various techniques that we can do on this, and again, we're going to get into this more on Saturday. So I don't want to talk too much and spoil the fun for the debate. But some of the data has demonstrated that prospective randomized controlled trials have demonstrated reduced reintervention rates when doing this compared to enteral stenting. And we were part of the group that looked at using EUS-guided gastrojejunectomy versus surgical gastrojejunectomy. What we found was when it came to the composite endpoints, tolerating oral diet, tolerating any diet at hospital discharge, and time to chemotherapy, was all significantly better using EUS-GJ. So definitively, I think we're seeing more and more opportunities there, and more data is going to come out, but we'll talk about that more on Saturday as well. Some other cases just to kind of go over. So, other ways that we're seeing EUS in bypass opportunities are managing patients with afferent loop syndrome. So here's a case of a patient we encountered who underwent a Whipple procedure and unfortunately had recurrence of their cancer. And so after recurrence, they developed an obstruction of their outlet. So an efferent enteral stent was placed in the efferent loop, but unfortunately, they then developed an afferent loop syndrome, where the afferent loop is obstructed and they develop jaundice and pain. And so what we opted to do in this case was to do an EUS-guided enteroenterostomy, where essentially what we saw was that one of these loops of the afferent loop were in close approximation to the efferent loops. And so we could potentially perform drainage in that way. And so here you can see the procedure as we perform it. Initially send in a forward viewing scope and leave a wire so that it's easy for us to introduce our EUS scope so that we can ultimately identify the dilated loop of small bowel from the afferent side. And so when you look at the data to date in comparison to enteral stenting for patients that have afferent loop syndrome, not a lot of studies, small studies that are really case series, but what they've been able to demonstrate is the need for reintervention as compared to enteral stenting is significantly lower. And so here you can see how easy it is to identify some of those dilated loops, then deploy the lumen-opposing metal stent and instantaneously, have the drainage, the bilious drainage, and then if we need to, we can dilate and perform ERCP. But in this case, we just opted to allow the drainage take care of the problem. And so other ways that we're seeing EUS in bypass interventions are patients with Roux-en-Y gastric bypass in order to perform ERCP. As you're aware, when a patient undergoes a Roux-en-Y gastric bypass, the excluded stomach and duodenum are now not in a good continuity for us to perform a routine ERCP. So options include a lap-assisted ERCP or performing an EDGE procedure, a US-directed gastrostomy ERCP. And so here you can see, you know, a stomach pouch that we identify. And under EUS, we can identify the excluded stomach. It has this characteristic sand dollar sign. And we can then just perform FNA, but really it's an FNI, fine needle injection, where we're actually introducing our needle and then filling the excluded stomach with contrast and dye, and then ultimately use that as our target, like a pseudocyst, to deploy a lumen-opposing metal stent. And now we can dilate that and then introduce our ERCP scope and perform ERCP through the lumen-opposing metal stent. And so this gives us an opportunity now to then perform ERCP and not necessarily have to go to the OR and have all the challenges that are associated with that, or do an enteroscopy ERCP. And when it comes to, you know, this network meta-analysis looked at rankings of performing EDGE procedure versus lap-assisted ERCP versus enteroscopy ERCP, and what they were able to demonstrate was really procedure time was significantly better when it came to the EDGE approach, and adverse events and technical success were equivalent between lap assisted and the EDGE approach. And so as such, that has really become kind of a standard of care for us. You know, I tend to prefer performing EDGE procedures unless the patient has a stone and is getting the gallbladder out at the same time, then I'll go up. But it can get kind of tedious arranging schedules and being able to do that in a lap-assisted approach. And now we have, of course, one-stage opportunities where we secure the stent and take care of things at the same time. And so just talking a little bit about the beyond, you know, with EUS, where are we going now? A lot of this has to do with tumor ablation. And so here's just an example of an individual with a cyst that was found incidentally after they underwent a CT scan of the abdomen and pelvis. And after undergoing an EUS, fine needle aspiration showed an elevated CEA, cytology demonstrated high-grade dysplasia. And so in this opportunity, you know, this was consistent with mucinous cystic lesion that could be potentially managed with a cyst ablation. In other words, performing a chemoablation. And so a lot of this work has been led out of the group out of Penn State with Matt Moyer's group. Essentially, you know, this can be done in a couple of different ways. But what they've been able to do, what some of the concern with this is high risk of potential pancreatitis. But what they were able to actually demonstrate out of Penn State was in the CHARM trial was essentially using a chemotherapeutic cocktail without alcohol really eliminates that risk of post-procedure pancreatitis. And the complete eradication of these cystic lesions is actually very good, almost 70%. And so here you can see how this is performed. Essentially, you aspirate the fluid out of the cyst, and then you replace it with the same amount of fluid you aspirated with a chemotherapeutic cocktail. In this case, paclitaxel, and this is what we use at our institution as well. But you can see really the remarkable outcome after. You know, this patient would have likely required a Whipple procedure for this type of lesion. There you see the cyst, there you don't. And so, you know, great opportunity to avoid a huge surgery using EUS guided ablation. And so a couple other things just to touch base with you on. This was an interesting case we encountered, 41-year-old female who presented to an outside facility with right upper quadrant pain, fevers up to 103 degrees. She had these recurrent episodes that sounded like cholangitis since 2005. So for 18, 19 years. And, you know, would have these intermittently abnormal LFTs. And so when we talked to her further, she said that, well, there was a nick of her bowel when they did her cholecystectomy, and we tried to get the outside hospital records, but there weren't any. And when she had an ERCP at the outside hospital, you can see that the cholangiogram just ends abruptly at the level of the clips. So we were suspicious that she likely had a hepatico, you know, jejunostomy. And here you can see on the MRI the dilated intrahepatic biliary tree. And so when we obtained a CT scan, this is playing. There we go. You can see that there's air in the biliary tree, but also there's a loop of bile that comes in close proximity there. And so What we opted to do was to look at this as an EUS-directed enteroenterostomy EDI procedure in order to perform ERCP. And once I'll show you here, now you can see that loop of small bowel, probably more appreciated better, loop of jejunum that comes in close proximity. We thought that that was likely the site. And we could see here also that the duodenum came in close proximity. And there you can see that loop of jejunum. And so what we opted to do was perform that EUS-directed enterostomy. So here you can see from the duodenum or stomach, we can see that loop of small bowel and simply stick a needle into the jejunum and then start to flood it with contrast and dye if need be. And as we continue to flood it with dye, we confirm that it is a blind limb. And here you can see the blind limb indeed is there where it ends right at the clips. So then, though we couldn't see any contrast filling in the ducts, we were pretty convinced that was the anatomy. So we opted to deploy a lumina-posing metal stent to gain access. And just in the interest of time, I'll kind of go through this quickly. Plus, because I think I took a lot of time doing this procedure for some reason. But ultimately, we deploy our lumina-posing metal stent. There you can see the distal flange, and then ultimately the proximal flange is deployed. And so we can then dilate it and then ultimately obtain access to it, 11 days later and perform ERCP through that lumina-posing metal stent. So here you can see, just using a cap-assisted technique, go through the pylorus and then right through the stent. And then here it's not very clear, but it's clearly jejunum where the biliary orifice might be. We see a little tinkling of bile and a little pinpoint opening. And so in a very non-sophisticated way, I play with the wire here until I see it go somewhere and then ultimately get it to go into what looks like a biliary jejunal anastomosis or hepatocojejunal anastomosis. And then you can see the cholangiogram with the stricture. So ultimately, we can just dilate that and then place a plastic stent, and this patient's done great. So almost 20 years of having intermittent cholangitis, and it just took understanding the anatomy and interventional EUS to cure the problem. So, when it comes to Eddie, I think, good technical success in the series that have been described to date, and definitely you need the anatomy to line up to perform the procedure. And I'll leave you with this final case. This was actually a case done by my colleague, Dr. Kraft, but an 89-year-old female presented with recurrent pseudo-obstruction. And she had multiple comorbidities, was not a good surgical candidate. We had done multiple colonic decompressions. And so ultimately what we opted to do in this case was a Lamb's colostomy. So essentially using a lumina-posing metal stent, we deployed this from the sigmoid colon to the skin and put a bag over it. And she's done great without recurrent pseudo-obstruction. So I think really this is more of the beyond that we're getting into, but definitely opportunities as you get more and more into interventional EUS. So in conclusion, I think EUS is revolutionizing the practice of GI endoscopy, offers safe, effective approaches to staging diagnosis, drainage, ablation, bypass, and beyond. Gold standard remains individualizing the care. We're doing risk-benefit analyses. If there's, you always want to have those discussions and look at what's in the best interest of your patient. And thank you all for your time and invite you to our WISE course in 2026.
Is the next presentation? Want to say anything? Yeah. All right, we're just loading up Dr. Gabbard's presentation, but thank you, Sham, for this incredible talk. Eric really showed up the basics, and you've really taken up to the next level on what you can do with interventional EUS and beyond. And hopefully, you'll get to see some of these procedures on Friday tomorrow. So our next speaker, while we load up his presentation, is Dr. Momin Gabber. Dr. Gabber is a director of endoscopy at the University of Cincinnati, associate professor of medicine, and a true expert when it comes to resection and third space endoscopy. Like Dr. Gabber said, that he and I shared the same training many years apart. Obviously, he was a few years ahead of me. Just so you all know, I'm pretty young still, But Moment has been instrumental in my third space journey with several phone calls as I've ever started embarking on new procedures. So true pleasure to have you here to talk about EMR, endoscopic mucosal resection do's and don'ts. So please, Moment, thank you.
Thank you, Bilal, for the introduction, and thanks for the course organizers. And just to clarify, it was only 2 years. I was ahead of Bilal only 2 years, not more than that. And it was also worth mentioning that our senior partner is Dr. Thakkar sitting right there. Sham was few years ahead of me, and we all trained under Doc Plesko and the amazing group at BIDMC. And I think Bilal put that in the context when he put his talk before me to respect seniority. So I'm excited to be here today and to be talking about a resection topic, which I enjoy. This is our UC Medical Center, where I'm fortunate to work with an amazing group, and I invite all of you, if you're around Cincinnati, to visit us. These are my disclosures. These are our learning objectives today. So our focus will be on EMR. And similar to how Dr. Law mentioned, big part of what I'm going to talk about today, although we're going to support some with the studies and results, big part is personal experience and do's and don'ts and tips and tricks. Sorry. To cover that, this is going to be our outline. We're going to talk about types of EMR and then steps of EMR and then conclusions at the end. So we'll start with conventional EMR, which I hope most of you have got a chance to do in their fellowship so far. It's the most common technique of EMR, which we commonly refer to as just EMR. But of course, there are other types and iterations of the technique. The whole idea of conventional EMR is that we are expanding the potential space in the submucosa by injecting a lifting agent to expand that space and be able to resect a mucosal lesion without injury to the muscularis propria layer. So this is a simple demonstration of how the technique works. We'll start with the injection needle. Your target is to inject in the submucosa, whether you're using a house-made solution, saline with methylene blue or other things, or one of the commercially available solutions, which are so many of them right now. And once the lesion is lifted adequately, you would select a snare, which we're going to go into the details about how do you select snares and different types of snares. And with that snare, we're going to grasp this lifted lesion, apply some suction through the scope, and that would help us grasp on the lesion. And once the lesion is grasped, we apply electrocautery and let the heat do the work, and the lesion is eventually resected. Once the lesion is resected, we evaluate the site, whether this is a site that would require closure or no closure, and if there are any complications of the site as well. But the fact is that there are several types of EMR. So EMR techniques is not just a single type. Endoscopists over time have developed more iterations of the EMR techniques to be suited for certain indications and locations. So we have conventional EMR, which we briefly described, and then there is CAP EMR, band EMR, and one of the recent members of the family, underwater EMR or UEMR, which is a very interesting technique. CAP EMR, we're not going to spend a lot of time there. It's not as common now. It's being mainly replaced by the next technique that we'll describe, which is band EMR. But the whole idea of CAP EMR is that we're using a distal attachment, a cap that has a snare fitted inside the cap. And what you do is that you get close to the lesion, you suction the lesion, whether you inject or not inject before. You can inject to help with suctioning the lesion inside the cap. And once the lesion is suctioned inside the cap, you close the snare, apply electrocautery, and the lesion is resected. Again, this is not very commonly used now because we are leaning more towards band EMR, which has the same idea of creating a pseudopolyp, but band EMR has a lot of indications now. The main indication for band EMR is in the esophagus for Barrett's, nodular Barrett's lesions that are relatively on the smaller side of the spectrum. The idea is that you use a bander, either a commercially available kit or your regular bander, apply the band to the lesion, suction, deploy the band, and then use the snare to cut that pseudopolyp that you just created. Please don't ask me in the questions whether we should cut above the band or below the band. It doesn't matter. Just do not try to cut through the band because the heat is not going to go through. But above the band or below the band doesn't really matter much. Although there can be some debates about that. The youngest member of the family is underwater EMR. And underwater EMR was first described by Dr. Ben Muller in 2012 and his group. And it's interesting, when they were doing EOS observations, we typically fill the lumen with water to help with ultrasound examination. And they noticed that during EOS, when they fill the lumen with water, that the muscularis propria layer will remain intact and circular in shape to give the organ its shape, while the mucosa and submucosa would move inside the lumen floating like seaweeds. And hence, they thought that if you don't need to inject, if you just fill the lumen with water or saline, as we will explain later, and you can just resect without any injection. And it really works. It takes a leap of faith to move there, but it really works. So this is a demonstration of how the technique works. We're in the colon. You're filling the lumen with water or saline. And as you can notice, the lumen is not distended anymore. So one of the advantages is that you can resect a relatively larger lesion with a smaller snare, and you are not injecting at all. So theoretically also, it can save some time from the injection. And I'm a big believer in that concept, is that when you inject, you actually expand the lesion, so you make it bigger. So it takes more time and effort to resect the lesion. With underwater EMR, you're just making everything smaller and relatively faster. You can also do closure underwater, which I enjoy sometimes. The only limitation is that if you run into bleeding, you will have to deflate the water, fill with gas, CO2, and deal with whatever you're having. But closure underwater is also good, provided that you have good preparation for the colon. And that technique is not necessarily just for the colon. You can use it in other locations too. Of course, if you're going to use it in the stomach, for example, the patient will need to be intubated to avoid aspiration. But colon, rectum, stomach, and duodenum, we even do underwater ampulectomies. We don't have videos here, but it's one of the good techniques as well. So again, underwater is gaining popularity. This is a recent meta-analysis published in GIE comparing conventional EMR with underwater EMR across 7 studies with a total of about 1,200 patients, about 600 in each group, conventional versus underwater EMR, and it showed significantly higher en-bloc resection rates with underwater EMR. It also showed that the recurrence rate, consequently, since you have higher en-bloc resection rate, as you would expect, your recurrence rate is lower in the underwater EMR group. Another Japanese study published in Gastroenterology comparing both techniques. They have about 100 patients in each group, and this one was designed for only lesions that are between 10 to 20 millimeter in size, and they noticed that they have a higher en-bloc resection rate and R0 resection rate with underwater EMR. So speaking of en bloc and piecemeal, it's very important to solidify these concepts because they are critical concepts when it comes to resection. So en bloc and piecemeal is a gross description of the lesion. So if you resect the lesion as one piece, that's en bloc. Anything more than one piece, that's piecemeal. On the histologic side of things, R0 means absence of the highest grade pathology at the lateral margins of the lesions. So for example, if you are resecting an intramucosal cancer and you don't have cancerous tissue at the lateral margins, but you have even low-grade dysplasia, that's still an R0 resection. R1 resection is the opposite, where you have the highest grade pathology at the lateral margins. Again, remember, you would be only able to have a viable assessment of the lateral margins if you remove the lesion en bloc. So you have to remove it en bloc and then assess the margins. Now we'll move to the do's and don'ts of EMR. And once you've done your due assessment of the lesion, determined that this lesion is amenable for EMR, injection is the first step. And in my opinion, it's the most critical step. It's the make or break step, really. It can make your EMR very easy and very straightforward, or it can make your EMR very complex and it takes a lot of time. And another thing to remember from our training is, I remember like on my first or second ERCP, Doug was saying, make sure you take a picture of the ampulla. It's not related to EMR, but to ERCP, take a picture, because at the end, you'll see how much you mucked it up from your attempts to get there. Same thing with the polyp. Make sure that you inject it adequately to avoid causing trouble for yourself as you go forward. So when it comes to injection, the goal is to perform submucosal injection, not superficial mucosal injection, not injection in the muscularis propria, which is not going to expand, and preferably not injection in the peritoneum or the adventitia. So it's an adjustment to get your needle into this submucosal layer. There are different techniques to make that adjustment. Some operators would suggest that you push your needle deep and then you inject as you pull the needle out. That's one technique. Of course, it's much better if you are able to get into that layer to start with, and this is something you get over time. This is a video kind of showing this simple, straightforward injection into the submucosa. It's very important also to track the volume of the injection. So my nurses in our unit are trained that at every cc, they would let me know. That's very important. You want to know how much you're injecting. It can give you also an idea if you are in the right layer or not. If you're injecting 2-3 cc's and there is no lift, there's something wrong. You're not in the submucosa for sure. So they are trained to do that. And actually, they are already counting how much you're injecting, similar to how you do with epi. They count that for other purposes. So just let them speak that out loud and let you know how much they're injecting. And as a general idea, with en bloc resection, less is more, which means that when you try to take the lesion out en bloc, you don't want to inject too much. You want to create a nice bleb that you can grasp with the snare in one piece. And one of the things I've noticed over time, earlier in my career, I would tend to inject more. It gives you this sense of safety that you're pushing the muscularis propria away. But then as you get older and you get more experience, you inject less and less and less. And that makes sense, again, especially on en bloc resection. Piecemeal is more forgiving. You're going to go through the lesion, so that really doesn't matter that much. So for injection pearls, recognizing that injection is a very critical step in EMR is very important. And you want to develop a sense for how much is enough. And that's going to come with experience. And it's going to come also with comfort level. Again, there is a drawback. If you don't inject enough, you can cause a muscle injury. So you have to be aware of that as well. And in general, for en bloc, you want to keep injections efficient and targeted. And I would say train your eyes to see and enjoy the beauty of that perfect lift. Resection is like an art. Even when I go in and evaluate a patient for ESD, I usually do like an upfront endoscopy or a colonoscopy. And at the end, I look at the lesion and say, like, this lesion will look amazing on the wall outside the patient. So you want to enjoy looking at those lesions. And in general, don't settle for good enough when you can achieve elegance with your injection. Do not over-inject. It's not like when we're doing ESDs and POEMs, we can always tell our fellow inject like crazy. It doesn't matter. You can keep injecting. It's not going to cause any harm when you're doing ESD or POEM. But in EMR, it's not like that. Once we injected, now is the time to pick the right snare. And if we're saying EMR is an art, snare is like your brush. So you have to know what types of brushes you have, like an artist, and pick the right brush that works for this lesion. So pick the right snare. When it comes to snares, we have different sizes of snares, we have different shapes, and we have different wire types as well. So when it comes to size, I have this simple equation. If it's en bloc resection, the size of the snare is the size of the area after the lift. So once you lifted it, the size of this area would be the size of the snare. I don't pick a larger snare to give me better grasp because it's going to grasp more stuff, and that stuff can include muscularis propria, and you don't want that to happen. Unlike for underwater EMR, as we'll mention later, you can pick a smaller snare. So I have a different equation for underwater EMR. In piecemeal EMR, in my practice, I typically rely on the 15 millimeter rounded braided wire snare. That one works best for me. Again, this is an operator preference. So if you go back to your fellowship program and say, I'll only do piecemeals with a 15 millimeter snare, don't do that. I don't want you to be kicked out of training, and we're not going to have space for you this year. So unless you are targeting, sometimes when we do piecemeal EMR, you have an area that on advanced imaging looks as precancerous. So you want to target that area. I would treat that area as if it's an en bloc area. I don't do that anymore. I typically do ESD when we have those areas. But if that's a practice and it's an acceptable practice, target this area and treat it as an en bloc area. You want to get it out as one piece. When it comes to the shape, we have rounded snares, oval snares, and hexagonal snares. Rounded snares typically are symmetric. They evenly distribute the power and the closing force and the current, and that's why I love them. They are typically my workhorse snares. The oval snares have wider axis, so it can allow you to grasp more tissue, especially with those laterally spreading tumors. I do not like them. I love the even and the symmetric size of the rounded snares, but the oval snares are good snares as well. The hexagonal snares have an advantage of having these flat edges, so it can have better grip and stability on the tissue. Again, there are not as many of those hexagonal snares now, and I don't use them that much. When it comes to the wire type, you have two types. You have either a braided wire snare, which means there are several wires all braided together, or you have a monofilament snare. And every snare has its advantages and disadvantages. The braided wire snare has lower impedance. So when you cut with it, it's kind of smooth, even cut, but in the same time, it's kind of slower cut. You can feel that there is like more drag on the tissue as you're going through. Also, that snare has more surface area, so it can give better coagulation and hemostasis as you're cutting through. On the other side, the monofilament snares, they have higher impedance. So they are very sharp. They can cut faster, but remember, cutting faster can have a risk that if it's a sharp snare, you can go through the polyp before the heat effect exerts its coagulation and cautery effect on the blood vessels in the tissue, and you would run into what we call the cheese wire transection, which is similar when you cut a cheese with a wire. You're not using any heat, it's just that force, and that can result in some bleeding and possible complications. Now you've picked the snare, you injected the lesion. Next is your electrosurgical generator. So this is the workhorse for the procedure. You have to be very familiar with your generator. For the sake of time, we're not going to go into the deep details, but just few quick tips about electrosurgical generators. The pad placement really matters, and that's the grounding pad. So the location of the pad on the patient's body is important. Actually, the closer the pad to the target area where you're operating, the shorter the distance the current has to go through the body of the patient. Remember, all of these devices we're using are monopolar. So it means that the current is going through the body of the patient, unlike the bipolar equipment that we might use in certain situations. So this might not be very evident with the advanced generators we have now that have all of these mechanisms and would adjust the current. depending on the resistance in the patient's body. But if you have a good sized patient and you're doing like a rectal lesion and you're putting the pad like higher up on the shoulder of the patient, for example, you would notice that. So it's very important. I typically put the pad closer to the location where I'm operating. The other thing is that you have to know your generator modes, and we're not going to go into the debate whether you use cut current or coag current. There's a lot of discussions about that, but just make sure you understand the mode that you're using and you're comfortable using that mode. And always think from safety perspective. Avoid uncontrolled cutting. Like one of the common examples, early on, you're excited, the lesion is there, the tech connects the cord to the snare, and you don't have the foot pedal. You ask them to bring it over, and someone steps on the foot pedal, and then you have an uncontrolled cut. That's a serious and avoidable adverse event. So do not connect that cord until everything is all set up, you have everything in place, and you're ready to go. So now we're all ready. We're familiar with the generator. We're ready to cut the lesion. So typically you want to put your lesion at your 6 o'clock position. This is kind of an iteration of the technique. We're using a snare tip anchoring method here. But in general, you want to anchor the tip of the snare, whether you're cutting and doing a snare tip pre-cut or not. And once you anchor the snare, you would notice that I'll actually let the snare push my scope back as it's opening. And that keeps that anchoring force there around the lesion. So I ask my tech to open the snare slowly, and I'll loosen my pressure on the scope so that snare would push the scope back and open, and you're right there. The lesion is right there. So once you go down, you apply some suction, not too much, not too little. With conventional EMR, you can do more suction than underwater EMR, for example, and then ask your tech or nurse to start closing the snare slowly. You want to make sure they are trained and know how much force to be applied, because if it's kind of loose and it's not snug, you're going to lose the lesion. If it's too snug and the lesion is not that big, you can have like a cold cut through the lesion, and you don't want that to happen unless you're intentionally planning for a cold snare EMR, which is a whole other debate, and I know we have a full debate about that. So if you're planning, we're talking about hot EMR, and if you're planning to do that, you want to make sure that they know how to close the snare. Once this is done, it's time to cut. So the cut is going to go through the cautery. So let the cautery do its work. I always ask my tech to kind of close slowly to let the cautery effect work. If it's too fast, you're going to run into the mechanical cut issue and you will run into bleeding. If it's too slow, there is excessive thermal energies being applied to the tissue, especially if you're using a coagulation current, and that can result in other damage as well. And again, it's an art. So closing the snare should feel like this is like a symphony. It's like a music. You hear the beeps of the electrocautery system, and you know exactly when you've read the right tempo, if you'd say. And once this is closed, the lesion is removed and everything is looking nicely. As you can see this nice, beautiful resection bed with no other organs, and you will not be saying at the end that these are really good scissors and you cut more than what you were supposed to. So now that you've resected the lesion, you're so excited, but there are still more work to be done. So after the lesion is resected, my first priority is to look at the resection bed. That's number one. I don't care about the specimen. With exception in duodenum, you don't want to lose the lesion and goes into the small bowel unless you are interested in doing a single balloon enteroscopy after the resection to retrieve the specimen. But if it's in the colon, if it's in the rectum, anywhere except duodenum, it's not going to go anywhere. So I don't worry about the lesion. I inspect the resection bed for any complications. The two main complications that you're looking at are bleeding and perforation. If there is a perforation, you want to detect that immediately and close it. And then if there is bleeding, you can deal with that, and then you retrieve your specimen. So you've dealt with the resection site. Now it's time to retrieve the lesion. Few things to remember here. If you are doing a resection, an upper resection on a non-intubated patient, if you're using EMR, you do not want to use suction into the cap. You want to retrieve the lesion into a Rothnet. It's safe and reliable. You don't want to be asking your IP colleague to go retrieve a polyp from the left bronchus after you made it fall across the larynx. I'll try to kind of skip through for the sake of time now. This was a quick underwater EMR slide. I think we'll have to skip that, but the whole idea was underwater EMR. Do not apply too much suction, unlike you do with conventional EMR. The snare size, that's my equation for the snare size when it comes to underwater EMR. Lesion size -5 millimeter. Smaller snare will work. And saline is better as a conductive medium than water. If you have a small polyp, it's not going to matter that much, but the larger the polyp, saline is going to help more. EMR is safe, effective, and potentially curative for benign and malignant GI lesions. Different EMR techniques fit different locations, match the method with the indication. Underwater EMR is a validated alternative to conventional EMR with higher en bloc and R0 resection rates. An injection is an art. Strive for beauty and effectiveness. Slow and steady wins when closing and cutting with the snare. Always secure the EMR site before chasing the specimen, except in the duodenum. And thank you.
All right. Thank you so much for that excellent talk. We're now going to move on to the Brian C. Brower Distinguished Educator Memorial Lecture, which would be Endoscopic Management of Complications by Dr. Alan Barkin. And like I mentioned before, we just want to highlight Brian, who was a dear colleague and friend, an amazing educator. We miss him. And so thank you so much for giving this lecture on his behalf.
Good morning, everyone. I must admit, for the trainees here, you're seeing a lot of passion in the lectures. I mean that. It's very nice to see. It really is. So I would like to thank the organizers for the privilege of speaking to you today. It's a topic I don't usually cover. I'm known mainly for bleeding, but I'll try and cover a number of different aspects, and you'll see it'll cover a number of things we've talked about, and that we'll see throughout the rest of the meeting. So the role of endoscopy has tremendously evolved over the past 30 years. It's useful in primary adjunctive diagnostic therapeutic modalities and in managing complications. That's what we're going to focus on. This will be an overview, so I had to pick and choose because it's a huge area. I chose some topics that I saw were not covered in the lecture, and because you'll hear many others both today and during the cases. And my main objective is not to show videos and pictures again, because we'll be seeing that throughout the cases. What I want to do is provide you for a review of the rationale and the overall approach, as well as some of the societal recommendations, but you'll be amazed to see how the societies don't agree on things we do every day. It's actually quite frightening, and we maybe want to discuss it as we go along. So what I've selected to do is talk about post-surgical settings. We'll discuss post-bariatric early surgery complications and post-surgical biliary leaks. And then we'll discuss post-endoscopic procedural settings. And I chose to talk about post-pulpectomy bleeding as well as ERCP-related bleeding. I hope you'll find those interesting. So let's talk about the management of early complications after bariatric metabolic surgery. So a couple of key concepts. It should be done in multidisciplinary manner, with interventional radiology and the surgeons co-managing the patients. You need to consider the patient as a whole as well, not just the endoscopic aspect, but comorbid medical issues and psychological issues by the patients. And it's very important because you're dealing with complications already, so it's already a different area when in dealing with patients. The indications have to be there, and the patient has to understand and provide informed consent with the situation at hand. The endoscopist, in addition, needs to not only know the endoscopy, but needs to understand the operative report and the post-surgical anatomy, which can vary quite wildly, as you know, in post-bariatric surgery. Common reasons for performing endoscopy in this setting are a result of either persistent upper gastrointestinal bleeding, so we'll talk about bleeding, obstruction due to severe torsion of the gastric lumen at the GJ anastomosis, or acute staple line leak, so we'll talk about those three. In each of these, endoscopy is often indicated as the initial therapeutic modality, and a couple of broad general aspects are obviously you need to use CO2 insufflation and be cautious advancing the endoscope as in all fresh post-surgical timing, because the staple lines are fresh. So with regards to bleeding, if there's significant bleeding, have a low threshold for GA with the airway protection, considering the body habitus that the patients often have at that step. And also don't forget they've been on GLP-1 agonists somewhere along the way. It may be an issue depending on whether they're back on it or not. And as well, consider even an overtube if you need to go in and out continually to evacuate clots. The AGA, best practice recommendations, favor through the scope clips, but we can consider, and we'll discuss this tomorrow when I discuss bleeding with you in a more general way. You can consider using hemostatic powders, cap-mounted clips, or endoscopic suturing. Avoid thermal approaches, however, in this particular context, because the fresh suture lines are there and are quite friable. In addition, don't forget many of these patients may have to go back on antithrombotics with prophylaxis subsequently. So you may want to stay away in this context from a thermal approach. With regards to luminal obstruction, those causes are usually due to either edema or to hematoma formation. They're different than the later post-bariatric surgery stricturing that is more related to stenosis and fibrosis. Positioning of large caliber self-expanded metal stents is usually the way to go in this context, 15 to 20 millimeter diameter, with or without anchoring. I'm sure we can discuss this during the question session, whether you choose a partially covered, fully covered stent. There are advantages, disadvantages. You need to obviously anchor the fully covered stent appropriately. On the other hand, it's easy to remove, but it may migrate and so on, and you get a more watertight seal with a partially covered as opposed to fully covered. We'll talk about that a little bit. The anchoring can be done with either thuroscope clips or cap-mounted accessories. If the obstruction is at the GJ anastomosis in the patient post Roux-en-Y gastric bypass, placement of a lumen-opposing metal stent can be performed if the anatomy permits. And a functional stenosis is difficult to comprehend, but because the surgeon, for whatever reason, has made it such that there's too much of a kink in the post-operative anatomy, this may need to be dealt with, particularly post-gastric sleeve, and may require a thuroscope clip or larger balloon dilatation, depending on the appearance of the area and the full surgery that was done. We move on to staple line leaks. So staple line leaks most commonly occur along the staple line of the proximal stomach, immediately below the angle of His in patients after a sleeve gastrectomy, or at the GJ anastomosis for patients who've had a Roux-en-Y gastric bypass. The pathophysiological mechanisms are, as usual, related to local ischemia. Interestingly, also mismatch in the staple height selection that the surgeon has performed. And for sleeve gastrectomy patients, may reflect downstream stenosis, as I was mentioning to you, at the incisura angularis, or high intraluminal pressure because of a poorly compliant stomach. And all these issues need to be dealt with because it's not just a leak that occurs. You need to understand what the rationale behind the leak is, because you may be dealing with a distal stenosis that is contributing to the whole process. And if you don't deal with that, it'll be a continuing problem. So most leaks are not present upon completion of the operation, and they develop over the subsequent weeks and often in setting, as I mentioned to you, of downstream stenosis. So please keep that in mind. Endoscopy is more successful for acute leaks earlier on, less than 6 weeks following surgery, and you can use either endoscopic suturing or cap-mounted clips. Recurrent leaks are frequent when primary closure methods are used in isolation. So this may come up on a case-by-case basis, but obviously sometimes you actually need to keep open the pocket of the actual leak itself, rather than just closing it blindly. It may not heal the process, depending what's the underlying mechanism contributing to it. And failures would include poor tissue integrity from ischemia and inflammation, difficult getting a perpendicular view to be able to really optimize the repair, and failure to address, as I mentioned, the high intraluminal pressures caused by concomitant downstream gastric stenosis or anastomotic strictures. So you really need to understand the whole process, the whole mechanisms leading to the leak. Now, diversion therapy can be done using a self-expanded metal stent and can be useful when combined with percutaneous drainage, depending on the situation, especially of early leaks. The diversion therapy facilitates early commencement of the diet. So the idea is the patient can then start eating a little bit more quickly. When longer length stents are needed, it can address downstream gastric stenosis. I'll show you a picture of one of those. And both partially and fully covered stems have been used with advantages and limitations. As I told you, you need to weigh whether you want a full seal or not, whether it needs to be anchored properly, and whether it needs to be removed more easily or not. And that needs to be tailored, although most of us use usually stems that we anchor, fully covered stems that we anchor. Techniques attempting to close a leak might not be the ideal treatment strategy, as I mentioned, particularly after 6 weeks when the leak site is mature and epithelialized, and thus keeping the fistula open with intraluminal drainage may be optimal. So you need to think about that. Again, what is causing the problem and not just blindly close it, because it may not be the key to the solution. When evaluating the response to therapy, it's important you need to look at the ability for the patient to tolerate the diet, as well as the decrease in the size of the perigastric cavity, not just look at the opening of the leak orifice. And that takes a little bit of experience in order to understand that. The internal drainage, if indicated, is most commonly achieved through double pigtail stents through the leak with or without necrosectomy. Septotomy, I've actually never done that here. It's like a Zenger's diverticulum, where you go ahead and use cautery in hands to open up and open up the whole septum. And finally, endoscopic vacuum therapy, which has been, I think, a game changer. And it's interesting, I have an identical twin brother who's actually a liver transplant surgeon. And we did this first vacuum one maybe 3 years, 4 years, 3.5 years ago. And I came to him and said, you should try this. And they say, we've been using this for decades. It turns out the surgeons know this. And as I'll tell you, not only does it actually suck up what is present, the secretions, but it actually promotes a vascular revascularization of the area, which I was not aware of. So the success rates, if we talked briefly about vacuum, because I think that's what we're going to see more and more in this context, is success rates exceed 80%. You can do it either intracavitary, putting in the actual vacuum directly in the leak pocket, or intraluminally, or both. If intracavitary, the applied negative pressure promotes drainage of the infection, improves tissue perfusion. This tissue perfusion is what my brother told me, and I thought he was a typical surgeon, making it up as he goes along. It has clearly been shown, so it really has something to bring to it. Traditional sponge needs to be replaced every 3 days to avoid tissue adherence, and they now have a vac stent, which is, I'll show you a picture of it, very nice, all-inclusive device that allows you to position the vacuum at least intraluminally. And it may simplify management with success rates. You always have to worry when you see 100%. I'll wear my epidemiology hat for a second. It's still small numbers, but there are meta-analyses now, no randomized trials, obviously, but clearly the performance is actually quite good. If unsuccessful, this is important to realize, but the surgeons know this. Fistula jejunostomy, conversion from a sleeve gastrectomy to OI, gastric bypass, and total or near total gastrectomy with esophageal jejunal anastomosis are preferred. You don't go and just repair the chronic leak. You actually have to revise the entire surgical montage to deal with it. So there's a couple of examples. This is a sleeve leak. You can see, I don't know why at times you don't see the pointer. There we go. So you see here the presence of the leak itself, and then you can see the opening intraluminally, and shown on with a contrast injection. And then what you have here is one of these big stents present. I'll try and show it to you here, the so-called mega stent present right through, and eventually the leak that has healed. So that's an example of, as I mentioned, the putting in SEMS. Another example would be the pigtails, putting in to try and get drainage. So again, you have here the leak, presence here of the stents being positioned in place. This is the luminal appearance, and eventually healing of the actual stent. This is an example of the vac stent that I told you about, where you can actually position the vacuum intraluminally in order to improve the situation. I'm not sure why, but there's my screen has frozen here. I'm not sure if I'll just try and forward it. I'm not sure why it wasn't going together. Okay, good. It's now back in sync. So that was for post-bariatric surgery, management of biliary leaks. So iatrogenic injury of the biliary tree is associated with several types of lesions. It can be related to strictures early and late. It can be related to leaks, and you can have transections, obviously, as well. Bile duct injuries may have different causes, such as clipping, burning, direct damage, and cutting, but usually there is a component of devascularization of the area, and it's a vascular injury, which is why it may present acutely or chronic or with a delay. Biliary leaks are the most commonly reported postoperative biliary injury, and certainly the ones we put, unless you have a hyper-specialized practice, is post-lap chole, where the incidence is about 1% or so overall. ERCP can help confirm the diagnosis of a biliary injury, decrease and eliminate. The idea is you want to eliminate the pressure gradient across between the bile duct and the duodenum, and that you reestablish preferential transpapillary bile flow and allow the leak to heal. So it's pretty standard, pretty straightforward rationale. Endoscopy is the approach of choice in most leaks and results in a remarkably high success rate, over 90%, particularly in the lap chole, post-lap chole, because of the type of leaks. I'll come back to that in a second. But biliary leaks, particularly post-transplant, have different grades and can be very complex, severity, complexity, and that will determine both the optimal approach and the success rate of the endoscopic approach that you select. And so there are a bunch of different classifications of iatrogenic biliary injuries. The one that's most probably quoted is that from Strasbourg. And what I show you here is a leak from a typical leak post-lap chole or post-chole, which would be cystic duct or the duct of Luschka, which has persistent leak. But you can also have a right posterior duct that is involved, which either just leak or fully transected. And sadly, you can also have common bile duct injuries as well, particularly if you've had devascularization in an attempt to identify Charcot's triad at the time of surgery. So there are varying practices in the endoscopic management of straightforward leaks, so the type A, which are by far and away the most common ones. Interestingly, this is an area for someone who loves evidence-based medicine. This is horrendous because there is no good data. The data are very low to low evidence. Timing of intervention. Nobody's quite sure when the best time to go in these leaks are, but usually within 2 to 3 days. Patients can be very uncomfortable, which will push you to go ahead. But if they have a percutaneous drainage for whatever reason that's been put in place, it can wait a little bit. The ideal timing of intervention is unclear. It would depend on the presence, the amount of volume and discomfort for the patient, associated sepsis, and the presence, as I mentioned, whether you already have a percutaneous drain in place or not. Sphincterotomy. Do you do a sphincterotomy or do you just do a stent or do you do both? So I can tell you why this will never be answered. It's a question of statistical power. You'd need thousands of patients to figure it out because either of them work very well. But so nobody knows whether you should just go do the sphincterotomy and that relieves the gradient of pressure, or you'll go ahead and do a sphincterotomy, put in a stent, or just put in a stent altogether, which theoretically would be lower risk. All have been done, all work well. I'd say most people do both. The idea is then, do you want to try and bridge the leak or not with a stent? And again, that's not unknown right now. I think the more complex the leak, the more so you want to go ahead and bridge the leak. If it is anatomically feasible, it makes good sense to do it, but the data, unfortunately, are not great. Then the size of the stent. Nobody knows what the ideal size of a stent would be. Do you use a 7 French or 10 French? Most of us would use a 10 French stent in place. And in high volume leaks, failure of internal drainage, there's low evidence, but most would go ahead and put in a fully covered SEMS or put multiple plastic biliary stents. But the fully covered SEMS work very well. And I think most people are going in that direction. If you would put biliary stents, you need to put at least 3 to at least get a 20 French combined diameter opening. The duration of stenting is also unknown. Do you put the stent in place and you wait 4 weeks and bring the patient back, or 8 weeks? I'll just tell you what I was taught a long time ago. There's actually a small study that was published in abstract form only, where they put nasiobiliary drains in patients at the time of cholecystectomy, and then who had leaks, and then they followed the patients. It took 5 days to heal the leak. This is uncomplicated post-cholecystectomy leaks. So we usually would wait much longer, just practically speaking, bring them back at about 4 weeks. And in patients who have delayed healing, as I'll talk about in a second, for example, in a liver transplantation, you may want to wait a little bit longer, but not too long, that the stent would block. Issues that are left in place, leaks that are unclear, the biodegradable stents, they remain unproven, they're quite costly. Complete transection of the major bile duct is obviously a huge challenge for treatment via ERCP, often necessitates combination radiological, surgical, endoscopic approach, or surgical reintervention with Roux-en-Y hepatocogygenostomy, typically following external biliary drainage to help control the situation. Different endoscopic techniques have been successfully used and they include a combination of nasobiliary drainage, sphincterotomy, stent placement. And I won't discuss altered anatomy because it's being discussed at other times during this course. Post-liver transplantations, as I alluded to, are an issue. Interventional endoscopy has become now the most common method to treat those biliary complications from liver transplant. However, they're clearly more challenging, both from an anatomy point of view and from the patient profile point of view. Different endoscopic techniques have been used. They include placement of nasobiliary drain, sphincterotomy, stent placement, same tools that we use, but a different approach depending on the patients. Here too, the goal is to decompress the biliary tree to guide reconstruction. However, as I mentioned before, compared to the post-chole setting, the post-transplant leaks are more challenged to manage and also take longer to heal, presumably because of the immunosuppression that they receive. Finally, post-trauma, post-traumatic leaks. Recent years, the treatment of hemodynamically stable patients with sustained hepatic trauma has shifted, and clearly endoscopic is now the way to go, as opposed to what used to be operative management. ERCP here has been shown to be quite helpful, both in making a diagnosis, establishing therapy, and I didn't realize this, but has actually decreased mortality in some series. So sphincterotomy with or without stent placement can successfully manage such complications in most, not all, but in most patients. And as I mentioned, has decreased the mortality rates. Location and extent of biliary disruption, again, may complicate the approach. It's a case-by-case basis. It's more complex. And percutaneous biliary drainage may have to be done as an adjunct to provide decompression and facilitate diversion of the biliary leak. And the decision here obviously depends on the type of biliary injury with associated organ injuries and local expertise as to how to manage it radiologically, endoscopically. Next would be, so this is the most common that we see is post-pulpectomy bleeding. And I want to spend a couple of minutes for that with you. You've all dealt with it already. And it's amazing how we don't know a number of things here as well, sadly. So I won't discuss intraprocedural bleeding. We can discuss it during the question session, but I'll talk about post-pulpectomy bleeding. This occurs in about 6% of cohorts. And it's usually, and you need to tell these patients this. I remember I had this patient who was part of the International Organization Committee, the Olympic Committee, and I told him you can't go anywhere for the next couple of weeks because you can bleed up to 2 weeks. And I live in Montreal, and he went to Korea for a meeting and bled over the Pacific Ocean. Luckily, he came into Vancouver and they were able to deal with him there. But you need to advise your patients that it is a 14-day time span for patients, although the textbooks say up to 30 days, but most of the colorectal cancer screening programs have taken the first 2 weeks as a definition for complications. So now there are a bunch of issues. Prevention. Patients on antithrombotics who are candidates for endoscopic removal of a colorectal lesion over 20 millimeters. You need to individualize treatment. You need to balance risks and benefits. I refer you to the ACG guidelines on the management of patients with antithrombotics that I co-chaired. It was published, I think, 3 years ago now in the Red Journal. Interestingly, I put a star here because the Europeans and the American societies don't agree. Some say 10 millimeters, greater than 10 millimeters, you need to stop the antithrombotics. And others say greater than 20 millimeters. Between 10 and 20 millimeters, you can probably go ahead and manage. And there are some randomized trial data suggesting that on clopidogrel and aspirin, you can remove polyps up to 50 millimeters in size without trouble. But it's limited and the interpretation is varied. An example of why there's a difficulty in achieving guidelines on this across societies. Now, if we look at non-pedunculated polyps, the recommendation is to use cold snare pulpectomy. It's very clear for diminutive polyps and small up to under 10 millimeters because they lead to complete resection and low complication rates. Hot biopsy forceps, I presume you know, is out. It's been out for a while, although the French still say that it's okay to use. I lecture at the Paris French meetings regularly, and they feel it's okay. Most other societies have said no go at that point in time, because not only does it provide incomplete resection, but there's issues of transmural burn and bleeding. Cold or hot snare pulpectomy has been suggested. This is a moving target. That's why there's a star here. For sure, up to 10 millimeters. I think most polyps are being done by cold snare, as I mentioned. 10 to 15 millimeters, I think most of us are going towards cold snare pulpectomy. We're talking about non-pedunculated right now. Between 15 and 20, there's a moving towards that you see some publications now. Interestingly, over 20, I won't discuss it here, but you should know there are 3 randomized trials and they've all shown that probably, yes, with cold snare, you get less of bleeding, but you have more retention of tissue and recurrences. So I think over 20, I'm not sure we're going to be moving to cold snare, preferentially over hot anytime soon, but it'll be interesting to hear what the experts in the room have to say. So over 20, EMR is a preferred method, but I put a star here too, because as you know, ESD is taking over the world, particularly after having been in Japan and Korea for a long time. The French took it over. Jérémy Jacques, probably one of the best known endoscopists worldwide right now, has vulgarized it. So the whole of France does ESDs now and do much less EMRs, and it's catching on in North America as well, and has for a number of years already. So just be aware of that. Prophylactic closure of defects over 20 millimeters in size is clearly has been suggested. Interestingly, there too, where you have randomized trials and meta-analyses, the societies still don't agree. So it's clear that the polyps have to be over 20 millimeters. That's benefit. It has to be right colonic. It's not clear that the more proximal, more distal lesions benefit. And obviously, if a patient is going back on antithrombotics, it's another reason to push you to go ahead and to do prophylactic closure. And the serrated polyps should be used using cold resection techniques. Pedunculated polyps, if we move on, prophylactic mechanical ligation if the polyp head is more than 2 centimeters, or if the wall, the thickness of the stalk is over 5 millimeters. That's recommended by some societies, but not by others. And hot snare polypectomy for pedunculated polyps over 10 millimeters. So this is still hot for the pedunculated polyps over 10 millimeters. That's pretty much agreed to. Treatment of intraprocedural bleeding is a little bit unclear whether endoscopic coagulation, grasping forceps, mechanical therapy, dilute epinephrine, even hemostatic powders and gels have been used in that context. We can discuss it if you have specific questions. So this, I don't want to spend too much time, but just to show you how it's so the preventative approach, even the risk factors were still unclear. You have the risk factors here. You have the American Society recommendations from 2020 and the more recent European recommendations, American and European here. And you can see that they don't agree on polyp size, polyp type, polyp location, removal technique, intraprocedural bleeding, use of anticoagulants, and with patient comorbidity may be a risk factor. So there's still a lot we don't know in this area, unfortunately. So now, if we look at how to manage it, through the scope clips has been widely used for the initial management of this, and they were recommended by the ASGE. The ASGE will be coming out with a guideline shortly on lower GI bleeding that includes post-polypectomy bleeding recommendations. After pedunculated polyp removal, the clip is deployed perpendicular to the stalk to ligate the feeding vessels. If you're dealing with a sessile polyp, the clips should be put in a place to tamponade the bleeding vessels, so slightly different to close the mucosal defect. There are no comparative studies, clip versus thermal, and the decision to use one or another will depend on your expertise in the case. Cap-mounted clips have been used, and hemostatic powders also have been used. Many people criticize the hemostatic powders because, as you know, the resting time is about 24 hours, but the recurrence rate of bleeding, post-polypectomy bleeding, is very low, so that makes it not an unreasonable consideration in that context. With regards to wide field EMR, I just wanted to show you one thing. I'm not sure how you practice, but I can tell you in Canada, all the post-polypectomy bleeds are admitted to hospital, basically. And I just want to convey the message to you that many do not need to. So this is out of 1,000 patients, 62 had bleeding. A full 55% of all those who came back could be managed conservatively, either were admitted but were not endoscoped. And the factors for predicting moderate severe bleeding is hemodynamic instability and low hemoglobin, but intervention is only if they have frequent ongoing hematochezia, a high SA score, or they needed transfusions. If not, they do not need to be endoscoped. They settle down on their own. And the decision model suggested that the number to treat was 4.5 to make it cost effective or not. So I put this respectfully to your consideration. Not all these patients need to be endoscoped when they come in with post-procedural bleeding. Last is post-ERCP bleeding, and I recommend to you this article published in Gastro just this year, a couple of months ago, which is excellent, of all post-procedural ERCP complications. So clinically important bleeding after ERCP is 1 to 2% of cases. Its associated factors include cholangitis, periampular diverticulum, thrombocytopenia, use of antithrombotics, hemodialysis, cirrhosis, or intraprocedural bleeding. These are all risk factors for post-ERCP bleeding. Post-sphincterotomy bleeding usually, but not always, occurs at the apex of the sphincterotomy site. Epinephrine injection or tamponade alone is helpful, but may not be good in the context of delayed bleeding, where through the scope clips may be difficult to put in place. If many of you have used it, as you know, because of the elevator, when you try and apply the clip, it kinks the delivery system and may impair the delivery. There are ways of getting around that. We can discuss it during discussion section. All efforts should be made to avoid injury to the pancreatic orifice. If need be, put a prophylactic pancreatic stent at the time you go do the bleeding, which may not be available. You may not be doing under fluoro. So these are all issues to consider. And endoscopic biliary decompression may be indicated because clots may block the biliary tree. With regards to refractory cases, primary salvage is done with fully covered SEMS. That's the way to go at this point now. And for very refractory cases, it's rare, but transcatheter arterial embolization. Powders have been used. We actually published showing that you block bile ducts if you put powders in indiscriminately. But if you know what you're doing, if there's a plastic biliary stent in place, that's not an issue. And finally, hemobilia, bear in mind, can also be related to other reasons such as dilatation, biopsies, RFA, or photodynamic therapy. This is an example for you, just to give you an idea. The top line would be a couple of fully covered SEMS that have been put in place to tamponade the bleeding area, and below would be actually placement of a through the scope clip, and you can actually see the bleeding site indicated by the black arrow post-sphincterotomy. So in conclusion, digestive endoscopy has an important role to play in the management of post-procedural complications, both surgical and endoscopic. Appropriate resuscitation and timing is key. You need to stay abreast of the evolutions. There are new methods of thinking about the issues and new accessories that are being developed, as we discussed. Available expertise and equipment are key. And as I always do for whenever I give a talk on endoscopy procedures, you need to have a multidisciplinary approach. You need to put your personal pride aside, and you need to do what's best for the patient. And that may indicate solely endoscopy, but may require radiological and surgical colleague multidisciplinary collaboration. So please keep that in mind to optimize patient care. Thank you very much for your attention.
Thank you so much, Dr. Barkin, for this tour de force. Our next speaker is Dr. Helmut Messmann, who's professor of medicine at the University Hospital in Augsburg. He was a former president of the European Society of Gastrointestinal Endoscopy, and he's a little jet lagged, he told me, so he got in late last night from Germany. And you know, if you ask where Augsburg is, he said that's where Oktoberfest is. So when you visit him for Oktoberfest, you can go and see some ESTs with Dr. Messmann. So he's going to take us into third space, essentials for acquiring competence. Thank you so much.
Yeah. Thank you for this nice introduction. Thank you to the organizers for inviting me. It's a pleasure to be here, and I'm really honored. It's the first time. I was flashed by these wonderful presentations. And being here for the first time, I'm always wondering to whom I speak. I mean, you are fellows, but fellows in Europe is quite different. We have fellows who don't know anything, and we have fellows who are experts. So may I ask you, who is doing third space endoscopy? Okay. So I think then my lecture should help you too, because it's a bit basic, and I apologize if for those who do already third space, it might be boring. The next question to me would be, what is third space endoscopy? Does it include ESD? Please raise your hand if you think ESD is third space endoscopy. Good question. No, I really didn't know until yesterday evening. I made my presentation. I thought third space endoscopy are techniques, tunneling techniques like EPORM, GPORM, THETPORM. Then I saw your program, and you have a workshop on third space endoscopy, including ESD. So I was in trouble. I completely reorganized with my jet lag, my lecture. So coming back to the definition, first space you have already heard, it's a luminal. Third space, the second space, usually we don't want to enter. The third space is the submucosal space. So it's space between the first and the second space. And this was my initial slide. You see third space endoscopy, diseases like achalasia, subepithelial tumors for stair procedures, GPORM for refractory gastroparesis. My lecture time is already over. It's right here. Should be hopefully wrong. Senke diverticulum was set perm under on. And you may know this slides from Haru Inui, who was the first publishing esophageal poem in 2010, where he showed if you make a tunnel at the esophagus and then you enter the stomach and then you perform a dissection of the muscular layer and the sphincter and you close your tunnel. This is E-poem. And the same came up with G-poem, where you also perform a tunneling technique. You enter the submucosal space and you dissect the pylorus. And finally, Z-poem. Z-poem means that you dissect this sphincter at the hypopharynx. Now, why could ESD be also third space endoscopy? This is a scheme who shows usually you start your ESD making markings, you inject, that's luminal, and then you start dissecting in the third space, in the submucosa, and looking at techniques like called pocket creation method, then it's for true. It's a third space technique right now. So you make a tunnel, and then at the end, you resect your tunnel. So you can say ESD is the mother of the third space endoscopy. So everybody was right when you voted. Now, and then I want to show you, the question was, what are the needs? How you can be an expert in the field of third space endoscopy? And therefore, I put in this slide how you learn ESD. Is ESD necessary to become an expert in third space endoscopy? And during my presidency, we published this curriculum on ESD, how we train people becoming experts in the field of ESD. And you see here the different steps. And the first step is always the background. You must be, you should be very precise in diagnosis. You should be experienced in luminal endoscopic resection, management of adverse events. And then that's a step where you right now, knowledge, theoretical knowledge, live conferences, meetings. And then you start hands-on, which will start this afternoon. You have first your observation in a center, animal trainings, and then you start your first patient. And I remember very well when I started my first patient in Augsburg, a couple of years ago, my first patient was a young lady. She was 25 years old and she came for a poem. And I told her, you're my first patient and I will do a poem. And she said, oh yes, I hope you will succeed. And I had no training, but I explained to her, listen, what I do right now is I do different steps of techniques, which I have performed hundreds of times. So making an incision, making a submucosal injection, making closure, making dissection. So these are all different steps putting together its poem. So it worked well. And so I was at that time, for sure, it was training, doing by learning. And now we have different options. You can now see when you start ESD, you need a couple of numbers, you need an expertise, you need a special caseload. And this is again showing the different steps. And what is necessary for ESD, for sure, is similar to the third space. You need a caseload in your center. You need your personal experience. And for ESD, it's important what kind of lesion you're dealing with. Where is the size of the lesion? Where's the location? And you know to need your weapons for the treatment. The injection solutions, the knives, the lifting, and the electrocautery. And there's a study from Pradeep Bandari in UK who showed the learning curve, for example, in Barrett's ESD. And it takes about 30 cases until you get experience. And then you are maybe an expert in the field of ESD. And we performed a registry in Germany on ESD. where are the leading centers? And at that time, it was Augsburg. You see, this is the only center who achieved at that time more than 140 cases. In the meantime, we have about 300 cases per year, and more centers increase now. And why is so important, this publication? Because it showed that the higher the caseload, the better the outcome. Similar to surgery, similar to each endoscopic procedure, caseload matters. And when we start with ESD, there is a recommendation in the curriculum, which I'm not very happy with it, because it recommends to start with the esophagus and with the colon. This is not my personal experience. Usually, my trainees start in the rectum and in the stomach. Then you can start in the esophagus. Cardio is quite challenging. The left colon, the right colon, and be careful with duodenum. We have some experience in my unit at the moment, Professor Yahagi, and I'm sure everybody in the room should know Professor Yahagi. He's a guest professor in my unit, so I employ him, and I'm very proud to have him in my unit. And he trains me now in duodenal ESD, and this is for sure, I would say, the highest level of ESD. Here is a very simple case of a ESD, a small lesion in the antrum, and this is what a trainee starts in my unit with. So precise diagnosis, looking at the lesion, using the underwater technique, because this has a zoom effect. Then in the stomach, usually you have to mark the lesion, you can inject, and then we will show you in the live course tomorrow, or maybe this afternoon, the different type of knives, and then injection, and then the dissection as shown here with the hook knife. And finally, you have a complete resection of this tiny lesion, which was curative. So a nice case where it's easy for a beginner to start. The most important point from my point of view is always the lifting, how to approach to the submucosa during ESD. And sometimes a very cheap option is the gravity. Use gravity, change the position of your patient, and sometimes you can really see the lesion better, and then the gravity helps you to get a better approach to the submucosa. Here you see some traction devices. In this situation, you will be frustrated if you use the clip line technique, which was introduced by Professor Oyama, also one of my teachers. Then you see it's very nice, the submucosal approach. Here you see another technique with lifting. This is a lesion in the colon, and oops, I cannot advance here. So I'll leave it a bit. I hope it's not too long. Otherwise, we skip it. It just showed you that there are some lifting devices. Here, I would like to show you a lifting device with a magnet and a traction. So if it takes too long, I think for time reasons, we should skip here. Coming to the next technique of lifting and tunneling, and therefore, again, third space endoscopy. This is a tunneling technique in the esophagus for a Barrett case. And you see it's almost circumferential. Here's the end of the tunnel, and then we leave a small tongue of regular Barrett's mucosa to avoid stricture, which is very demanding and a severe complication for patients. And finally, what I learn as a fellow from my teacher, Professor Yahagi, is underwater pressure ESD technique. And what is different to the regular technique? The first is the cap, the smaller diameter. And then you see underwater technique, again, a very precise inspection of the lesion. In the colon, it's not necessary to perform markings. I usually recommend in the esophagus and in the stomach, but not in the colon. So now with a dual knife and injection, at the distal margin. This is the first step to make an opening here. And then at the oral side, starting with the tunneling, and then you can proceed. And this is what I said, a new technique to have a lifting without any additional tools like clip line, like rubber band. And here you can see very nice with underwater pressure technique. Sometimes when you start, these bubbles are a bit disturbing, but you can flush it, and then with a dual knife, very precise cutting in this situation. And I think, yeah, here is a complete resection, and I skip here because then we save some time. Yeah, Professor Yahagi already mentioned, it's important, although if you get trained in a special field, to have a teacher. I have the privilege now not traveling to Tokyo. Professor Yahagi is in my unit and teaches us now for 3 months in this field, and I think this is a really big honor. Now I come now to third space, to the real third space. And we have a curriculum also published from the ESGE for POEM. And you see here, they have 3 steps. So the pre-adoption, then the training, and then the implementation. And what does this mean? The first step is, again, understand pathophysiology, indications, peri-procedural management, electrocautery setting, technical skills. So you should be an expert in upper GI endoscopy, in management of bleeding, and you should have experience in ESD. This is for sure an advantage. You can start with POEM without ESD, but in my unit, I recommend my fellows get trained in ESD, and then you feel a bit more comfortable for POEM. And then again, a step-up approach, observation by experts. So when we started in 2010, Professor Inouye was in my unit, teach me in the first case, and I traveled to Professor Rösch in Hamburg, who had at that time all the experience. And then I skipped this simulation and animal because we didn't have at that time. So as mentioned, I had my first patient was a young lady, and I started here. And I had no supervision. And I realized later on what is a complex case. So now, 10 years later, we know how we should teach POEM for beginners and for people who want to get trained in this field. And then if you want to implement POEM in your unit, use a prospective registry. Numbers, this is just, I would say, a recommendation of experts. 15 POEMs per year for an endoscopist or for a center 25. I mean, you should know your outcome. You can have 100 POEM, but if there is a bad outcome, then this center should not continue with POEM. Coming again to the esophageal POEM, you know, for achalasia, it's meanwhile a very, very well-known and accepted method. Before you start, high-definition endoscope with water jet irrigation is necessary, submucosal injection solution, and the transparent distal cap. Your knife, we usually use the triangle knife, but other knives are also like a hybrid knife. Coagulation forceps and the use of CO2 low flow is essential. Electric cautery, you should know what kind of settings are helpful, and these are how we use it. And then the patient is in general anesthesia, and then the supine or left lateral position. There is always a discussion for POEM starting at the anterior and the posterior wall. There were numbers of studies comparing this technique. There is no clear message which is the best one. So finally, the lower esophageal sphincter, it's important to measure it before you start, and then start with submucosal injection. You have heard from the lecture before, it's essential to inject in the submucosa to have a nice bleb. If you don't have this bleb, you're in the wrong in the wrong layer. After that, after that incision here with a triangle knife, make it not too long, but also not too short. Take if you have a cap like this here, you can enter easily the submucosal space with this. This is a cap from Fuji, and then you start your tunneling. If you enter the submucosa, sometimes it's helpful to enlarge a bit or to dissect the superficial submucosal fibers at the entrance. If you have entered like here, then it's almost easy to dissect the tunnel very safe. Here you see it's now within the submucosal space. And then the question is, when do we arrive at the GE junction? It's here visible by a narrowing of the tunnel. Then you know here is my GE junction, and there's almost the area where we have now to pass, and then to continue for another 2 centimeters. Again, it's helpful to measure the distance when you have you have the feeling you're at the end of at the area of the GE junction. You feel still during the procedure, this is still a high pressure area here, and then you start with dissecting. It's also helpful to look at the blue stained bulge. So if you look outside, go back, have a look, and you see this bulge, then you know, oh, this is where I am now at the GE junction. Although some vessels, the so-called perforating vessel or spindle-shaped veins, as shown here, show you that you are at a GE junction. And palisade veins, some people use a double scope technique, which we don't use, to be sure that you have approached some GE junction. Then when you start with the myotomy, where to start? Usually about 2 to 3 centimeters after the incision, not directly behind the incision, because you should have a kind of overlap. And then, as already mentioned, anterior, posterior, obviously no big difference in the literature. And here we use the triangle knife. And you see the circular muscle layers, and here the longitudinal muscle layers. Also, the question is how to perform. Shall we cut all the longitudinal muscle layer or just the circular muscle layers? Oops, the data are not clear in this field as well. So anterior, posterior, as already mentioned, no difference. Length of myotomy, obviously no big difference between 5 or 7 or more centimeters. Only in achalasia type 3, the length is important. As mentioned, selective or full thickness myotomy, no difference. Usually I try not to cut some longitudinal muscle layer. We see not so many side effects, but this is my personal feeling and not proven by big studies. Mucosal closure can be sometimes a bit challenging. Start at the distal part and then step by step grasp the lateral parts, and then it should be easy to close this defect. It's quite important because otherwise you have the risk, if it's not proper closed, that there is a risk of mediastinitis if you have an opening or leakage here. Challenging cases, don't start with this type of achalasia. A sigmoid achalasia can be really challenging and frustrating. So this should be really for experts. This shows you here the radiology image. And problems and adverse events. Luckily, we don't have so many, but bleeding can be very, very risky for the patient. And if it bleeds in this tunnel, you are sometimes lost because you don't see really the bleeding spot, and it's difficult to treat. So the best approach to avoid bleeding is to prevent the bleeding by precise dissection. And this is a disaster which should not happen, a spurting bleeding in the tunnel. Yeah, then you should try to grasp with a forceps this spurting vessel and to stop the bleeding. Mucosal tears can happen sometimes, burning effects, so they can be closed or should be closed. In this situation, my colleague used an Ovesco clip. Well, this is maybe, yeah, I'm not sure whether I would use an Ovesco clip in this situation as well, but it was helpful and the patient did well. But it's important to close such defects if you have it. Gas-related adverse events. So if you have a pneumoperitoneum, your anesthesiologist will tell you that you has problems during ventilation, and then this can be also an advantage. Just one study showing that POEM is effective. This was a large trial from Thomas Rösch, where we all participated, compared with surgery, and it showed the similar success rate, less severe events, but a higher number of reflux in the POEM group. Coming now to GPOEM, similar principle, similar approach to the tunnel. Here is an example showing the technique. The tunnel must not be as long as in the esophagus, so usually just 2 to 3 centimeters from the pylorus. I think this video is a bit long, so I will skip it for time reasons. Sorry for this. There was an important study, a shame-controlled study from Jan Martinek, showing that GPOEM is effective compared to the shame group, and therefore I think we can select patients. The majority of patients are those with patients after surgery or diabetes and some idiopathic reasons. So ZPOEM as the last POEM indication for Senke diverticular, similar approach. And there are a couple of techniques, the rigid, the flexible, or ZPOEM. You see here in this study, the complication rate is for the surgical approach the highest. Flexible seems to be the best in this comparison, but not, it was a retrospective analysis. And here is an example how ZPOEM works. You see here the opening in the esophagus, and then you see there's a diverticulum, and the approach is similar. You make an incision or you make a small tunnel. Here is a direct approach to the muscle fibers. So you make a cut and then you dissect on the lateral side of this muscle layers. You open it up and then you dissect first the submucosa on the left side, on the right side, and then you can dissect some muscle fibers. And here you see the muscle fibers, and now it's very easy and safe to cut these fibers with a knife. And I think for time reasons, I will skip here. You see here the dissection of the muscle fibers. And then after the procedure, for sure, closure is essential. And there is a randomized trial from Michael Kaminski comparing ZPOEM with the flexible endoscopic septotomy, published or presented this year in the ESG days. And you see, to my big interest, there was a higher complication rate in the flexible group compared to the ZPOEM. So this is a big surprise to me. Otherwise, there is technical success was similar in both groups. And at the end, just showing you that DPOM, the last indication where you have epiphrenic diverticulum, can be also treated in the same way. And I think this is now a video which we can skip because it shows similar to the THET poem. Here is a diverticulum. Here is the bridge of the muscle layers, and you also dissect this septum here and go down to the esophageal sphincter because there is in the majority motility disorders, and you have to dissect also distal of the muscle of this muscle bridge. Last indication is the so-called STAIR, submucosal tunneling and endoscopic resection for submucosal tumors, mainly leiomyoma in the esophagus. And at the end, I will show you what will become in the future. This is what we developed in Augsburg, AI-assisted third space endoscopy. What does this mean? It shows you here yellow, this is submucosa, orange is muscle layer, and then you see vessels. And this is maybe helpful, picking up the vessels, picking up the right plane where you have to dissect. And this can be helpful for ESD and for POEM. And this was a video which we performed after we did this POEM. This was a POEM case with a severe bleeding. My colleague didn't see the vessel, but AI saw this spot, and you see, zack. Perhaps if we had this AI online, that would be helpful, but this is just speculation, but shows you the future of this technique. Now, to conclude, to become an expert in third space, I think the societies like ESGE, and I'm sure all the ASGE, needs to introduce some curricula, how to train these techniques. And I think third space endoscopy should be performed in specialized centers. You need always a high caseload. You need a special infrastructure. For sure, you need endoscopic experienced endoscopists behind you, and need training and simulation equipment in your unit. And with this, I will thank you for listening, and I'd like to invite you next year to Milan. Maybe you come to the Olympic Games, but we would prefer if you come to ESGE days. Thank you so much.
Awesome. Thank you so much. Well, we'll have time for one or two questions to make up for it. So any fellows have any questions in the audience? Yeah, go ahead, Tom. Oh, can you turn on?
Can you hear me now? Okay, great. Yeah. So great question. So the question was regarding single session edge. When do we perform it? When do we choose to do two session? So really, as you know, we're creating a fistula from the pouch to the excluded stomach. Typically, we'll perform the single session edge in patients who are in need for urgent type intervention on the biliary tree. So someone with cholangitis as an example, someone with a leak as an example. But really, those are the ones where we will perform a single session edge. To secure the stent, there's a couple of different options you have. I like to secure the stent using the overstitch device, where essentially we throw two stitches in to hold the stent in place. I'll use a 20 millimeter lamps in that setting as well, and dilate it up completely so that we can minimize the force on the stent. The other option you have, of course, in that case as well, is the stent fix from a Vesco that works very well also. The disadvantage you get into with the stent fix is that sometimes you have to use a clip cutter in order to take it off, or you have to use a endoscopy scissor or endoscopy scissors to take the suture off. So it's a little bit easier in that regard to use the suture, in my opinion. But both work fine. Typically, if I'm doing that for a case like that, then I'll bring the patient back in a few weeks. When I remove the stent, I'll remove the sutures and everything like that at the same time. Yeah. Do you guys do anything differently?
I would say the same. I mean, in general, in our center, we try to avoid the single session edge in general, unless it's like absolutely indicated, the risk of just the migration. And you can salvage this endoscopically, whether like a fully covered stent or another axios through it. And we even have a published video GIE about like doing a notes procedure to salvage a migrated one, but it just takes a lot of time. So our protocol is very similar unless it's like an emergency. We try to do it as a 2-session.
Any other questions from the fellows that taught us? On other hand, yeah.
Thank you. Hi, I had a question about the injection for the EMR. I get different guidance from various attending. So do you inject beyond the polyp or the lesion and then come proximal? And do you inject into the polyp?
That's a good question. So there are different parts to it. So first, you want to know if you're doing an on-block EMR versus a piecemeal EMR, because the technique is going to be different. If it's an on-block, your goal is to create this nice hump without much left of the surrounding tissue and take the polyp as one piece. And in that case, most likely your polyp is ranging around 20 millimeter at most or 25 millimeter at most. And in that case, I would inject in the polyp if you're using a commercial lifting agent, because you would notice even the direction of the lift is different depending on the type of the agent used. So some agents are more gel-based and they have this vertical lift. So if you inject in the polyp, it just starts to go up. If you're using saline and methylene blue, typically the direction is not like a vertical lift, it's more of a lateral lift. So that might change the technique. And remember, the submucosal space is a potential space, and you can change the direction of the lift even with your needle. You can direct the needle, and this is way more obvious with ESD. You can change the direction of the lift with the needle. But in general, what I do if it's an on block, a lesion less than 20 millimeters around that range, in the lesion itself, it spreads, lift it up vertically and cut it off. Piecemeal EMR is very different, and there are a lot of different opinions on how you operate. Some operators would prefer to start closer from the scope and keep moving towards the end of the lesion, and others would do the opposite. And there are pros and cons to each approach. If you do it from if you're in the colon, for example, you do it from the oral side towards the anal side of the lesion. You typically want to inject behind the lesion to lift it towards you, and you start taking it from there. But some others would even tell you would just do it from the anal to oral, and it still works. I prefer in the colon, for example, if I'm doing piecemeal, which we don't do as much now, typically more towards the ESD. But if we're doing piecemeal, we start from the oral towards the anal because you have better view of the lesion as you're lifting it towards you. I wonder if the other colleagues have different opinions on how you inject.
No, I agree. And one of the things I like to do is I like to work from when I'm doing the resection front to back. I feel like that allows me to methodically take the lesion in completion. Yeah.
Awesome. Well, we have time for one more question. Yeah, Ryan, you want?
So I just wanted to make a point back to the single session edge, because I have a hunch that many of you are going to try to do that. I think there's some things you have to think about that maybe don't always come across. Sham's talk was fantastic, and this is to piggyback on what he said about single session. First and foremost is the indication. Secondly is creation of the track. So you see all the videos and the papers that talk about this sand dollar sign. What you have to realize is that sand dollar view on EUS represents the gastric antrum. So while it's a great target to fill up the excluded stomach, it may not be a great place to place your axios. So it's totally okay to start filling the stomach there, retract your needle, withdraw your scope a bit further back and look for a spot higher on the stomach. You want a longer runway. If you're going to do this in one stage, you want a reasonably long runway going into the maybe more proximal gastric body, still avoiding the staple line, but trying to do this in one stage with an antral axios is going to be a recipe for disaster. To Sham's point, you better be ready to salvage this if it goes sideways. Esophageal stent, second axios, notes recovery, whatever it may be. The other thing I would make a point to say is oftentimes that sand dollar sign is seen from the blind jejunal pouch. Doing a one-stage edge from the blind jejunal pouch is going to be the highest risk of anything. If you're really going to take this on, particularly earlier in your experience, I think you really need to make sure it's gastrogastric instead of jejunal-gastric. So just some other nuanced things to keep in mind if you're going to go down that road.
Well, that was fantastic. And it's going to be a perfect segue to our discussion during lunch. So we'll take about a 10-minute break, and then we're going to have a working lunch where we're going to have this roundtable discussion. So just to keep on time, so we have enough time for hands-on, if we can make this process efficient. For also the fellows, make sure you sign in, because eventually if you sign in every day is the only way that your institution is going to get the travel grant. So make sure you sign in at registration every day, and especially if you haven't done it today. So we'll do a quick lunch break. Thank you again for a fantastic session, everybody, to our speakers.
Okay, we're going to get started again. Thank you guys for moving so quickly to get lunch. Thank you to all the speakers so far. This has been an excellent morning session. We're really excited for the hands-on afterwards. So Bilal and I were just talking. Part of the reason why we chose this as a roundtable discussion is, unfortunately, even though we can do amazing things endoscopically, we all have complications. They have many aspects that come with them, sort of the emotional, the professional. So we thought that this was something to introduce you guys to now. So just as sort of an icebreaker, since you guys are a little quiet, raise your hand in this group if you guys have ever been part of an endoscopic complication. Yep, all of us. And then raise your hand if the outcome has been pretty bad, including death. Yeah, I think we've all been there. So we have world-renowned experts up here. All of us have had complications. So Bilal's going to sort of set us off with a couple questions, and then we want you guys to feel free to jump in, ask anything you want to, but really to get all of our faculty up here, panel members, to share some of their experiences in dealing with this.
Yeah, I mean, we already met a lot of our faculty.
Here.
Turn the mic on. Okay. We already met a lot of our faculty, but just introduce our three other faculty members who haven't spoken yet. We have Dr. Sumit Singla from Henry Ford, and then we have Dr. Colin Noel, who's joining us from South Africa, who's also a surgeon and an endoscopist. So really excited to hear his perspective, and obviously Professor Hiro Isayama, who's joining us from Japan. So really excited to open this up. So we'll start with you, Dr. Noel, since you have both the surgical experience as well as the endoscopic experience. When the moment you have a complication, obviously Dr. Barkin's covered a lot about how you technically manage it, but what's going through your mind? Say you're doing an endoscopy and you had a perforation. Like, what's the thought process that goes through your mind, the emotional things that go through, or because you're a surgeon, nothing goes through and you're like, I can fix anything.
Yeah, I think when it comes to complications, I've got a bit of experience there, like all surgeons. But I mean, I think probably one of the most important things, and we don't teach people this quite often, is actually sort of recognizing the complication, because the earlier you recognize it, I think the earlier you can start dealing with it. So it's really about early recognition, and then, about staying calm and realizing that you don't have to hide away from complications. I think we grew up in an era where you sort of it's frowned upon to have complications, and I think that's, from the surgical side, is taught slightly different. I think it's inevitable that every person has a complication, and every procedure comes with a risk. And so you're not out of the norm if you're having a complication. I think that's the first thing to realize. Stay calm. And then, early on in your career, we teach our fellows to call for help sort of, as soon as they've recognized the complication, because having somebody there just who's not directly involved often has a level head. You're often a bit nervous. You've created sort of or done something wrong or something along those lines, which is often not the case. It's often the underlying pathology and the difficulty and the technical aspect of the procedure that's led to this. So to just recognize that, stay calm, and then go through the troubleshooting and ideally with a colleague. I'd say that would probably be the first thing that goes through my mind.
That was great. And it's nice to have the surgical opinion on things too. The two things when I read the title of this talk, the first was you've had a complication and now what? And I would offer that if this is the first time that you're thinking about a complication when it's happened, you've already missed the boat. And so I think you got to look backwards and think about informed consent and building trust with your patient and their family well before the procedure. I remember watching Raj and Joel Munzer at our live course when I was a fellow, and how much time they spent because they were going to be taking care of a patient they'd never met before. And they spent, dozens of minutes, if not an hour, getting to know the people and building trust. So I think that's something that you really should do if you're not seeing the patient in clinic before to go through the risks. You want to make sure you build that rapport and trust in advance. One of my mentors, Cyrus, would always say is are you the right person? Are you in the right place? And is the procedure indicated? And so these are just some things to think about because, again, once you have the complication, it's already happened. But you want to make sure you did all of the steps in advance to put yourself and the patient in the best place to succeed.
I guess what I would say is when we're talking about all these highly interventional procedures, as the interventionalist in the room, you have to have a game plan for all of your bailouts, all of the things that could happen and how you're going to handle them if they happen before you ever put the scope in the patient. I just think that's a good way to think about, hey, if this happens, here's how I'm going to fix it, so on and so forth. The other thing that I would tell you to piggyback on to Dr. Noel is you can't freak out. Everybody's going to look to you as being the most calm person in the room. In short of torrential bleeding and exsanguination, there's almost no scenario where you don't have 3, 4, 5 minutes to think about what the best plan is. If you have a hole and you need to turn off CO2, fine, turn off the CO2 and think about what your options are. But that kind of step and that kind of 3, 4, 5 minute period likely will set the tone for how things go for the rest of that patient.
A question for Dr. Montmany and Dr. Fan. What, when you had a complication and you've dealt with it, whatever you did, when you're going to disclose it to the patient or the family, how do you sort of approach that algorithm?
Yeah, I mean, that's the worst part of this, and you're like, you just entrusted me with your family member. They became vulnerable. And now I screwed up in some way, or just Murphy's Law took place, anything that can happen will happen. Usually I start down the road with just a statement of facts of what happened during the case. And then I try to own it because I think that's what patients want, is just to see that you're acknowledging that something went wrong and that you're respecting the fact that something went wrong. But then the next sentence out of my mouth after I've basically said, this is what's happened and here's why I am I see what's going on and I understand what you're going. My next sentence is, this is how we're going to fix it. And this is the plan. So kind of like what Dr. Law was saying, you have to know your game plan both in and out of these complications. You need to know Newton's third law of endoscopy, equal and opposites. You better know if you're going to do something, you better be out of the way to fix it and get out of it, or know the next steps of how to repair something that's gone wrong. And this is how you have to then break it down, because not only are your patients' families scared, you have to explain this as simple and step by step. And then, basically walk them through the next steps going forward in the simplest and direct, accessible approach that you can. You want to add?
So, thank you very much for many good information. So, I performed many pancreatic endoscopy. So, there are many complications that will be occurred. So, before procedure, so I explained to the procedure and the complication to the patient. So, but patient family do not know about such kind of the things. After the complication occurred, the patient family angry to me. So then recently we changed the step. Initially in the outpatient clinic, explain to the patient and write down the many papers. And so take these paper to the home. Then the family read these papers and agreed the not only a patient but patient family. So this is also one of the tips to decrease patient families angry. Other one is so after the complication, refer to the other doctors. So the endoscopist. So the surprising to for the my result. So the call to the other doctors, not only endoscopy but also surgeon or IR guys. So and these reference, it is from the patient side. It is so we so they trust to me. So because we struggle to recover this situation. So this attitude is very important to the patient family, I think.
Yeah, I agree completely. I do some medical legal work, and what we hear a lot from patients from that end is they get angry when they feel lost. They understand a complication may happen. We've consented them. We write little dot phrases in our notes when we see them in clinic that tells them the complications that may happen with a poem, with an edge, with whatever. And they can acknowledge that human error happens, but it's when they don't have the follow-up after or the clear disclosure that something has happened. So if they feel a sense that you're trying to cover something up, you're trying to protect yourself, something happened and I'm not taking ownership of it, that's when anger starts to seep in because they're scared. And so really taking ownership, and as Dr. Singla says, have a relationship with your patients. I had a patient, I took out an edge lambs, and then like 6 days later, she vomited like The Exorcist. And she went to another hospital, and in the middle of her hematemesis, she goes, did you get the hat that I made for your daughter for her trip to Colorado? She knew something happened, but it's the relationship building that keeps not only you protected, but makes the patient and their family feel protected as well.
I would say it's also like you want to set up the entire team for success. So like when you have these complications, you go from being this like, the star point guard or whatever to being the person that lays up the nice assist for the surgeon. You want to have all of the discussions with the family so that the surgeon can walk in, and if you have some dreaded perforation or whatever, that they'll be able to make the transition of the care even better. The worst complication I've had, it was actually very traumatic, was because someone at a different hospital didn't lay out all the possible complications. When they came to me, the complication happened. And so that assists, the possibility of so essentially, I had a patient with malignant esophageal mass. They put a fully covered stent in and left it in for 8 months. And the patient came to me with essentially, a GI bleed. I went and irrigated, and they exsanguated right in front of me because the stent eroded into the aorta. And the family, I had met the family basically, for about 15 minutes and said, I was expecting it just to be some esophagitis. I was never expecting this to be what it turned into. And they were furious with the person who never really talked about this. So it's about, setting up the next person for success for a possible complication, whether that be your surgeon or someone who may actually even come across this person in the future.
Go ahead.
Can I just add, and I know there's a question here too. When you mentioned the team, that's really great, that warm handoff and really communicating for the next step. But I want to also just piggyback on the team aspect, and I want to just call out one of the special parts about the Colorado course is the nurses course also right next door. And I popped over and listened to some of those talks this morning, and it's always amazing to me to see really engaged teams around us. And so my two fellows here will know in my room, I make sure everybody knows everybody else by their first name. And the room is lively with conversation the whole time so that everybody in the room can feel safe saying, and this happened to me, hey, I see free air under the diaphragm. And if everybody's empowered to recognize that complication earlier, when a complication happens, in addition to staying calm, I encourage conversation. Hey, Teresa, my nurse, what do you think we should do next? What do you guys think? Can we call in one of my partners to give a second opinion? So the more conversation around it and that team, I think, is really important to me.
So what I have is more of a comment, and thank you guys for all of these wonderful thoughts about complications. I mean, complications is the worst thing that we have to deal with, and we hope we don't deal with. But the more we do, the more complications we run into. But I like Sumit's point, and I want to add to that is that setting up expectations is very important, like before the procedure. And especially for some of the delayed complications where the patient, you're not going to be around when it happens, and telling the patient what exactly to do, patients do appreciate that so much. And one example I will never forget is a patient with an FTRD for an appendiceal orifice polyp. And it's known that the risk of appendicitis might be as high as 30% for those who have an appendix. And unfortunately, he was the one. He got appendicitis. But before the procedure, we were very clear about what needs to be done. These are the symptoms of appendicitis. You're going to come to the ER, inform them about this procedure. There is someone from our service on call. And what you will need is, unfortunately, a surgery. It's an appendectomy, but it's still better than a cecectomy if your cecum was to be removed for the polyp. So, and this actually, the interesting part is that I never got to know that he had the appendicitis until I saw him in clinic for follow-up. And the first thing he said is, "Thank you for letting me know about the symptoms of appendicitis. I had it. I went to the ER. I had the surgery, and I was released next day." So that was his whole experience. So setting up the expectation, and then the having your team all together. Actually, there is this book. I don't recall the name of the anesthesiologist at the Brigham, but the book is uh, the Checklist Manifesto. And it talks about how we should have a checklist in medicine to avoid complications, how it is in the airline industry. And he showed a study that actually, when the team members in the room know the names of each other, the complication management is way more efficient and complications are less. So when we're doing some of those like less common procedures like POEMS, ESD, or like a stare, I would typically start, although almost everyone in the room knows each other, we see each other every day, but sometimes you get like a new CRNA or something. I would tell them, before we start, let's have every one member of the team identify themselves. And in the OR setting, this is a routine practice. It's part of the timeout. They have to, everyone would say their name and identify their role. So when something happens, yes, you call them by their name, and they're actually more responsive. And that helps because management of complications is a teamwork, basically. Thank you.
I actually include that slide in most of my ERCP talks. It's Atul Gawande. He was a surgeon in Boston, and the book is terrific. And I think it can teach us a lot about how to manage stress and how to checklist a lot of different things. Thanks for bringing that up.
Other questions?
That's a great question. What I would tell you is a couple of things. I would challenge all of you if you're going to go into therapeutic endoscopy, endoscopy in general, but you have to be in, you have to have kind of insight into yourself and really truly understand what your risk tolerance is. If your partner wants to create every possible, EUS guided anastomosis that has ever been described, that doesn't mean you have to. So be comfortable with what your risk tolerance is, number one. Number two, you're 100% correct. You have to be able to compartmentalize enough sometimes to do the next case. Maybe the next case is the same thing that you just had a bad complication on. What I would tell you is maybe non helpful as it is. That's part of the deal. If this is the world we're going to live in, we have to be ready to, if this is your first case and you have a bad complication, you have 4 more, you have to find a way to get through it. At some point, you're 100% right. You have to regroup with your team and just have a little bit of a debrief, and make sure that everybody else is able to do the same, depending on what the complication is, what happened in the room, did the patient die, go to surgery, what it may be. Everybody's going to look to you in these situations. I have a pretty standard rule in my room with my fellows that if there's anything that I'm maybe uncomfortable with what the outcome is going to be or is super high risk, that's not something I'm going to let my fellow do. Because I think as a fellow, perhaps more than when you're faculty, these things can be very paralyzing if they happen to you as a fellow. And I just don't think that that's right. I think it's much better for me to be the one with paralysis and lack of sleeping and all of those things and have my fellow watch me deal with it. I think that's a much better use of their time and for them to see. But in the long run, when you're the boss in the room, you're gonna have to find a way to move forward. Maybe you take 10 minutes extra between cases and go for a walk, whatever it is, but you have to be ready to do it again as soon as possible.
Yeah, my rule is if I have a complication, I just take like 2 minutes after the case. I go to the office and I just don't put on anything that's stimulating. I don't turn on the Epic or whatever. I don't take my phone out or anything. I just let the adrenaline like kind of seep out. I let that rush just kind of go away. And then I have to just take a deep breath and just go on. But just taking that moment, it's not normal to have this happen and then go talk to the new person right away. It's the same thing when you all were residents, having a big discussion about someone or pronouncing someone dead in ICU and then going to your next patient and talking about, their DKA or whatever. That's just not a normal thing. So you have to just kind of like take a second, one, just like to respect the patient that you just unfortunately injured, but also respecting yourself a little bit and knowing that I still got this, I can shake off this loss, but I still have an obligation to the 8 other patients that I have today. And I have to be obligated to be on my best at this time. So taking that second to do mitigation of anything that can get you to be distracted.
I'm going to play a bit of devil's advocate here. I'm going to come back and say that it's important to realize that complications are going to happen to everyone. And whether you like it or not, if you're in interventional endoscopy, surgery, whatever it is, the complications are going to happen. In my experience, the vast majority of time, I mean, there are situations, but the vast majority of time, complications, if you go back and look at it, are almost unavoidable. So, coming to, if you've done it, how to debrief, in sense, we often, fortunately, a lot of our surgical cases are recorded, laparoscopic and robotic are all recorded, is to actually go back, sit with a colleague, and I'll come to that now, and go through your procedure. And the amount of times I review these with my fellows and with other colleagues, I say, look, unfortunately, or fortunately, I would have done exactly the same thing. And that's very reassuring to know that somebody, more experienced than you or somebody who's been there before actually would have done the steps exactly the same way and, didn't recognize the underlying anomaly that led to the complication, and come to liver surgery with all the, the duct variants and everything, it's going to happen to everyone. So that's the first. And then the second is the surgical programs, I think more so than the endoscopy programs, although it is sort of coming through now, is mentorship. So we have mentorship programs, EHPBA, we have mentors around the world that the mentees are sort of associated to. IHPBA is similar, our HPBASA, very similar. And it's very valuable to just have a mentor that you can phone at times like this, especially if you have a bad outcome like a death, is to phone through and speak to somebody that you trust, somebody that's taken a personal interest in you, somebody that's going to guide you through these situations. Because again, talking through it, often you're going to realize that it's actually unavoidable. There are times where it's different, and those are learning cases, and again, learning opportunities. And if somebody sort of comes down and barks at you, unfortunately, they haven't been in that situation, and then that's not the case, because even the avoidable ones are going to happen to you at some stage in your career. The big thing is to learn from it, to accept it, and coming back is to be as honest as possible with your patient, because honesty and transparency prevents further complications. So, I think mentorship and just going through the program, going through the procedure with a colleague, because more often than not, it's something that would have happened to all of us.
So I just want to make one comment. It's just really amazing that we've spent about 10 or 15 minutes talking about this topic that Michael just brought up. I think we're all talking about the second victim syndrome here, right? When he brought up this whole concept of how do you deal with this psychological aspect, I completely agree. Patient comes first, but I guess the point to take away from this conversation is that you've got to think about yourself as well. How are you going to take care of yourself after a complication? I bet you if I ask all these faculty members, internationally renowned, they've all experienced second victim syndrome at some point or another. Maybe the degree of this may vary and how you get impacted by complications. But the important thing is that you have some support system in place. Whether you want to do what Eric does, go walk away, take a walk, or if you want to just call a mentor or you want to talk to a friend, whatever it is, I think it's just important to recognize that, because this is what leads to burnout. This is what leads to us giving up what we absolutely enjoy doing day in and day out. So that's just something else that I wanted to add.
I would just really quickly, the importance, and this kind of going off what Colin was saying, is the importance of mentorship, but also interdepartmental mentorship is key. Some of the best people that have pulled me out of a complication and that rut that Sachin's talking about has been the surgeon. Not even just my own colleagues in endoscopy who are like, yeah, you could have done this. But the surgeon was like, Eric, duh, this is going to happen. And if you think my job doesn't have complications, you're out of your mind then, you're going to get through this. And so having that colleague across, in endoscopy, we think we're Navy SEALs and everything can do anything we want, but our surgeons still are, there to really still educate us, not just in the clinical sense, but professional sense. And so you really want to make that, cross that, put that olive branch around to the other departments around you to get you, because it is a intradepartmental complication often.
Thank you. Okay. Oh, one last final comment.
This is an excellent discussion. I would just add that when you have a complication, this is not the time to have pride. Modesty, humility is the most important aspect of managing a complication. It'll help you feel and resolve however long it takes for you to resolve it, but it'll allow you to be a little more compassionate toward the patient and the family, and it grows the entire unit and grows all your colleagues when you can share with them and ask for help every single time.
If I can just add one comment to that. So the best scenarios that have been studied for near misses and misses are actually pilots, right? So there's two kind of big events that have happened in the last 50 years. One is in Tuskegee, where a pilot drove landed the plane, but then drove the plane into a barrier and 175 people died. And when they went back and they looked at the history of this pilot, it was that he had had near misses, didn't have a debrief session, and had hubris, right? This was a learning event that then modeled how the FDA or how the the TA, whatever, TSA, changed their coaching of pilots. That then led to what happened in that Tom Hanks movie where he landed in the Hudson, right? Where he had had near misses. He had learned from those near misses. He had recognized the weather had just changed. There's a bunch of birds coming into the Hudson now that the winds have calmed down. He said to his co-pilot, "These are the three things I'm worried about." And in my mind, of the thing that I'm most worried about are these birds. And if the birds happen, this is my contingent plan. And what does he do? He does a miraculous save into the Hudson. And that hubris that Dr. Shaw talked about was what prevented him from becoming another Tuskegee. And I think it's really important that we kind of extrapolate from other data, from other near misses, from other big events, and learn that there are so many things that are apply into our little endoscopy room that we learn from other careers.
Perfect.
Thank you.
That was an excellent ending point. So great early morning session, great introduction and beginning to RMIE, which is going to be an amazing next couple of days. We're going to wrap up now so we can get you over and have you guys practice all these skills you're learning about. So in your badges should be your group assignments. We're going to go down the stairs, and at the bottom of the stairs, we're going to have our nurses who are going to come pick you all up, and they're going to have signs by groups. And we'll see you down there soon.
And a few other assignments before you guys go. Make sure again you've checked in, because that's really critical for your travel grants. Huge shout out to Christy Click on the back for making this course happen and all the work she's done. To Dr. Wani and Dr. Shah for their tireless efforts and their support and having this. We also have dinner at 5:30 for all faculty and attendees at the Hyatt Regency in Aurora. So we hope that all of you to see you all over there. And then we're going to do a group photo right outside as you get out of the stairs for all the faculty and the fellows downstairs at the, looks like it's a change in direction. Yeah. Oh, dinner's at Benson, so even better. So, all right, I'll take all the good words about it now.
Just take it back. Just fire her. Can we?
So, yeah. All right, we'll see you at the group photo and then we'll go to hands-on. Again, thank you. Big round of applause for all the faculty this morning.